like it's golden, golden. Living my life like it's 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 golden, golden. I'm holding
Bon matin tout le monde. Juste un petit coucou pour dire qu'on va débuter à 8h30 pile. 8:30. We're starting. Just to let you know. So if you have friends who are still in the hotel and you're texting or messaging them, 8h30 pile. Okay, 8:30 we'll be starting in about 8 minutes. Merci.
I can see clearly now, rain is gone. I can see all obstacles in my way. Gone are the dark clouds, had me blind. It's gonna be a it's gonna be bright, sunshiny day. I think I can make it now, pain is gone. All of my bad feelings have disappeared. There is the rainbow I've been praying for. It's gonna be bright, sunshiny day. Look all around, nothing but blue sky. Look straight ahead, nothing but blue sky. nothing but blue sky. Just look straight ahead, nothing but blue sky. I can see clearly now, the rain is gone. I can see all obstacles in my way. Gone is the dark cloud that had me blind. It's gonna be a bright, sunshiny day. Gonna be a bright, it's gonna be bright, sunshiny day.
Imagine there's no heaven. It's easy if you try. No hell below us. Above us only sky. Imagine all the people living for today. Imagine there's no country. It isn't hard to do. Nothing to kill or die for. And no religion too. Imagine all the people living life in peace. You may say I'm a dreamer,
Showtime. Oh, okay.
but I'm not the only.
Good morning, everyone. Bonjour tout le monde. Je vais vous demander de prendre vos sièges, de vous asseoir. Please have a seat. We're going to get started. We may have some people trickling in over the next few minutes. That's fine, but we want to get going because we have a lot of things to cover today. So my name is Rebecca Chassé, and I'll talk a little bit. I'm the MC for this weekend, and I've been working with the local organizing committee to offer this symposium this weekend. And I'll talk a little bit about my role in a few minutes, but before we get to that, I'm going to start with some land acknowledgement in French and in English. Reconnaissance du territoire. La ville de Saint-Jean au Ménaquesque est le territoire traditionnel des Wolastoqiyik ou Malécites. Les Wolastoqiyik ou Malécites, avec leurs voisins autochtones, les Mi'kmaq et les Passamaquoddy, ont signé des traités de paix et d'amitié avec la couronne britannique dans les années 1700 qui protégeaient leurs droits sur les terres et les ressources. We would like to acknowledge, honor, and pay respect to the traditional owners and custodians from all four directions of the land on which we gather. It is the traditional unceded territory of the Wolastoqiyik, Maliseet. This territory is covered by the treaties of peace and friendship, which the Wolastoqiyik, Mi'kmaq, and Passamaquoddy peoples first signed with the British Crown in 1726. So welcome, everyone. Bienvenue tout le monde. A few housekeeping items. So first, it looks nice out right now. Looks a lot better than yesterday. But in the event of a power outage, our designated muster point is going to be just outside by the big bay windows. Okay, so if the lights go out, go to the light. There's windows there. Just follow the light. That's where we go. Okay. Second thing, pour la traduction simultanée, simultaneous translation, the devices, si vous n'avez pas ramassé les appareils encore, ils sont disponibles sur la table, juste à côté de la table de contrôle audiovisuel. So if you want simultaneous translation today, the devices are back there on the little table just to the left of the audiovisual control center. Channel 1 is English, et le canal 2, c'est en français. Okay. I will talk a little bit. Vicky Hogarth, where's Vicky? Vicky, there she is. Okay, so there's Vicky. Vicky Hogarth is a journalist from CHCO. So her role this weekend is to be a media analyst for the event. We're really, really happy she's here. And Vicky has been connecting the symposium with some really exciting media coverage as well, which is really, I'm really happy about that because this is a symposium. It's a big deal. It's a really big deal. So a few other housekeeping items. So those of, if you have any questions, vous avez des questions, there are people wandering around with blue, not me, thank God. Ask your questions to people wearing blue. So Kathy over there is wearing a blue name tag. If you see someone with a blue name tag, they can answer your questions about who, what, when, what do we do, where are we going, what's for dinner, okay? My job, among other things, is I'm going to be a bit of a timekeeper. I'm going to help make sure that we stay on time for stuff and keep rolling along because we have a lot of stuff to do this weekend. Important, les salles de bain, the washrooms. That's always the first thing I look for, and I found them. So you just go out, okay, à gauche to your left, and then you're going to see a sign for boardroom at the Spencer, I think, but the washrooms are down that hallway as well. Okay, so if you need the washroom, that's where they are. If you want copies of the PowerPoint presentations that are going to be offered today, they will be made available after the symposium this weekend. Okay, you can ask for them, they'll be emailed. Yeah, so I'm going to talk a little bit more about my role. My name is Rebecca Chassis, and this, I'll just set the table for the weekend a little bit. So my role this weekend is to MC, and Kathy on the organizing committee asked a few of us who are going to be up front here to talk a little bit about why we're here, how we got involved. And when Kathy approached me a few months ago, it's actually because the committee wanted someone else. There is another media personality who has, I think, a connection with this organization, and she wasn't available. So, but she said, she told Kathy, this one, Rebecca, she's, good in front of a microphone. She likes to hear herself talk, and she can do it in both official languages. So that's they called me up and I said, yeah, I can do that. So up until very recently, I thought that was my role. I just bring a specific skill set up here to the podium. But then that changed recently. So I'm going to show you a photo. Lydia, do you want to put a photo up? Okay. So out of respect for this woman's family and her kids and her grandkids, I'm not going to tell you her name. And for that same reason, I've chosen to not show her face. Honestly, I have no idea how to get in touch with her family. But what I can say is that was my best friend. That was my best friend from our first day together in grade 1, right up to the day she ran away from home when we were 16. And from the day she ran away from home when she was 16 until the day she passed away in her home, it's 2 months ago, coming up this Monday. So in those 31 years, addiction was always a part of her life. And in those 31 years, of course, we grew apart because our lives just took really different paths, very different. And over time, she went from being a memory of a best friend to, I hate to say this, a bit of a ghost. And I feel when I think of that and I think back to those 31 years that went by, I feel bad and I feel guilty sometimes for having maybe been a half-assed friend. But everyone here in this room knows that that's how it goes sometimes when addiction is a part of the picture. So when she died 2 months ago and my mom called me up to tell me she had died, I went looking for her online because it had been 20 years since I'd seen her. And I was really scared I just wouldn't be able to find her. And I was also scared if I did find her, I wouldn't recognize her. But this photo is actually a still. It's a frozen still from a video I found of her on social media. And I haven't stopped watching this video since I found it. I've lost count of how many times I've watched this video. And there's two reasons, I think, why I keep watching this video over and over and over again. So I'll tell you what she's doing in the video. You can kind of see, but I'll tell you what she's doing. So in this video, she's in a boat and she's driving the boat that's going really fast. And she's on one of the Great Lakes. And it's really nice out that day. And there's like, the camera turns to the front of the boat and you can see these little fluffy clouds and it's warm. And the wind is kind of making these wispy whiffs of her hair, like just kind of blowing the wind. And she is, listen, her life wasn't easy and it didn't have a lot of happy in it, especially near the end. But in this video, let me tell you, she is some happy. She is some happy. Her life was really hard, but in this moment, she is having a really nice time. And that's the other reason I think I keep watching this video over and over and over again, because right after this second in the video, she turns to the camera and she is giggling. She's got a huge smile on her face and she sticks her tongue out to the camera in the exact same way she used to stick it out at me when we were kids and she was trying to get me to laugh. And that's why I keep watching it, because I did recognize her. And I was like, yeah, that's my friend. That's her. And so going forward, I think there's a third reason I'm going to keep watching this video. And it has to do with like the awesome people I've met just in the last 12 hours, like Katrina and Melanie sitting at your table last night, and the Mayor of Canterbury and Dr. Poole and Minister Shepherd, and all the people I've talked here who have arrived with, I can feel it, like a huge sense of urgency and caring and commitment to the work that we're going to do here this weekend. And so I think the reason I'm going to keep watching this video is not because I feel guilty for having been a half-assed friend, but I think now I know I can see us in this video. Like we can be the steering wheel on that boat, and we can be the boat on the water, and we can be like the nice fluffy clouds and all the things that gave her that, as shitty as her life was, that gave her that moment where she was happy. And I was like, there's my friend. That's the work we do. And we can help women like feel like themselves and look like themselves again. So from the bottom of my heart and from my beautiful friend, thank you. Thank you. So some of the other people I want to thank are the members of the local organizing committee who've been working for a year to get this thing off the ground. So I'd like to invite Peter Howlett, who is the president of Portage. He's a member of the Symposium local organizing committee, and he's going to give us an official welcome. So Peter, there he is. Thank you, Peter.
I'd like to start off by thanking Luc Desjardins, because I discovered that I had to read a letter and I didn't have my glasses. And he lent me his glasses. They work, and he's probably not getting them back. So thank you, Luc. As president of Portage, I take great pleasure in recognizing the organizing committee here this morning. And I'd like to take just a moment to mention Brianna Virtue, Colleen Foreman, of course, the chairman, Dr. Russ King, who means so much to all of us in Atlantic Canada, Kathy Rogers, Carol Tracy, Danbury Hicks, Peter Vamos, and I may have missed some, so I apologize, but they're very effective and they've been working considerably and for a long time in making this event happen. I want to also observe that on that committee, we had 3 board members, Dave Ferguson, Ron Murray, and Pat Rogers. So it's a very powerful group of people, and we're very fortunate to have had them working on our behalf. I'd like to observe the presence here this morning also of a good friend and longtime board member of Portage, who left us because she became Madam Justice Mary Claude Blais. I would like also to note the presence of Mrs. Tanya Cloutier, who's the Mayor of Canterbury, and thank you for being here with us. The other woman I'd like to observe the presence of and tell her to get lost is Fiona. It's made a big difference to the running of this conference, and I'd like to commend all of you on your presence in the face of Fiona. As president of Portage and involved in the substance abuse rehabilitation world for more than 50 years, it is always such an immense pleasure to partner in a high caliber, cutting edge symposium such as the Women in Addiction International Symposium today. Un immense merci pour votre participation. C'est avec plaisir que je débute ma bienvenue en lisant une lettre qui parvient du Premier ministre du Canada. I'm pleased to bring welcoming greetings from the Prime Minister of Canada. Thank you again, Luke. I am pleased to extend my warmest greetings to everyone participating in the 2022 Women and Addiction International Symposium, hosted by Portage Atlantic in partnership with the International Council on Alcohol and Addiction. This event provides an important platform for professionals and practitioners in the field of women and addiction to discuss current research and share experience and expertise. I am certain that attendees will benefit greatly from the many educational opportunities planned for the next 3 days, as well as from the chance to network with their peers from across the world. I would like to commend all those in attendance for their commitment to making a positive and lasting impact in the lives of women with addiction. You can take pride in knowing that your efforts bring hope and healing to your fellow citizens and set them on a path to a brighter future. It continues to be a challenging time for planning and hosting events. That is why I would also like to thank the organizers for offering this symposium in a hybrid format and for putting together an informative and rewarding program for everyone involved. Please accept my best wishes for an enlightening and engaging experience. Sincerely, the Right Honorable Justin P.J. Trudeau, Prime Minister of Canada. And Justin Trudeau has been a great friend of Portage for decades. I'd like to welcome all the in-person participants and the virtual participants. We have, it seems, in excess of 700 people, in total de plus de 700 participants. Now, apparently there's a map behind me somewhere. There it is. That describes, I've got one down here. It's very, very advantageous. That's quite a portrait of the places from which people are participating today and following this symposium. I think that's quite a that's quite a portrait. Many countries around the world have an interest in this subject matter, and the presenters and their topics have garnered great attention. I would like to reiterate the vision of the symposium: to remove the barriers to meaningful addiction treatment for women and their young children through improved understanding of the impacts of the social determinants of health. Ever present in our collective thoughts should be solutions in policy and in practice. Thank you to our co-hosts, the International Council on Alcohol and Addictions, and our partners, Atlantic Lottery, Nashwaaksis Lions Club, St. John Chamber of Commerce, and United Commercial Travelers Jack Kidd Council number 755, and our many sponsors. Merci pour votre participation. Thank you for joining in this event that will prove to be thought-provoking and meaningful to us all. And I think I turn you back, I'm not sure for certain, but Rebecca Bassey.
I'm here. Bring me in, please.
Thank you.
Is somebody listening?
Yep.
Yeah, just the technician. This is the interpreter speaking.
Okay.
If they can bring me in, we'll be all set.
Okay. Did you hear that, technicians? Okay, thumbs up from the technicians. Okay, that's good because we're about to start with our first panelist. I would like to invite Dr. Nancy Poole up here to talk to us about the wonderful initiative she has been captain of for 20 years, you said? More than 20 years? Yeah, okay. So Nancy Poole.
So thanks so much for bringing me. I'm really happy to have the opportunity to talk about this subject. As some of you I've worked with in New Brunswick know, it is sort of a pet story for me to think about bringing gender responsivity into everything we do around girls and women's health. So I've been working for 20 plus years, as mentioned, on all of these issues, preventing violence against women, reducing substance use harms, thinking about how we bring in Indigenous wellness approaches, advancing trauma-informed practice, promoting girls' and women's health overall, and doing lots of knowledge sharing like I'm doing today, and really trying to bring us together to foster collective action to improve health and equity. So that's sort of how I came to be here in the story of us all doing that. But today I'm going to talk briefly about why we should do gender responsive treatment, and then look at some guiding principles for how we do it. That were identified quite a long time ago by the United Nations, and bring in the current work in Canada that relate to those principles of gender responsive treatment. And of course, as a researcher, I'll bring in a few lessons arising from research, as well as clinical wisdom and lived experience as I go along. And hopefully we'll have some time together to talk a bit about how we build on this work. So sex and gender are among the most influential of all the determinants of health. And that's a lot why we're here today, is to think about substance use and determinants of health and how we bring an understanding of it all together. The sex and gender part of the determinants of health, the sex part, of course, is all about the body, the physiological, anatomical, hormonal issues, size, weight, body parts, chromosomes, all that part, and how important it is we understand how substances affect women's bodies. The gender part of it is another whole territory where we're thinking not only about gender identity, but also about gender roles, gendered relationships, gender norms, and power imbalances that really affect women's ability to access treatment and benefit from treatment. So here's a quick summary that the US, the NIH in the US once put together of all the ways in which sex and gender matter in substance use, in the mechanisms, those biological responses, in the consequences, in the risk factors and protective factors that we need to take into account in prevention, in the access issues and readiness issues and retention and outcome issues in treatment. And of course, lots about reproductive and parenting issues, how parenting roles and social stigma and child custody issues really play into how we need to respond to substance use problems in women. But before I, let me just go back one slide. Oops, I lost the slide, it looks like. Before I go on to talk about gender in the relationship to women, I just wanted to mention that a key part of being gender transformative as we do our work in substance use issues is really involving men and boys in this effort as well. So as much as we're trying to deliver treatment to women, we're also really want to engage men and boys in being a part of supporting women in that process. Here's two examples of where some of the folks in Canada have been thinking about that. From Saskatchewan, in thinking about how men and boys in the This Is Why poster can support women not to drink in pregnancy. And on the other side, the Dads in Gear program, a program about dads not smoking that has both Indigenous and non-Indigenous streams, but really lots about involving men and boys in thinking about different gender roles and substance use. So lots to think about in terms of sex factors, gender factors, and the intersection of those and intersectionality, race and class and culture, all being a part of it. And these three pictures here are things that we've done at the Center of Excellence for Women's Health in the last little while that talk a bit about the substances and sex and gender. And mostly today, I'm going to talk about the response, not the substances. But just to let you know, we have been looking at how we need to take sex and gender into account when we're working on methamphetamines, how we need to take sex and gender into account when we're thinking about low-risk drinking guidelines and alcohol, and how we need to think about sex and gender as we're responding to the opioid crisis. So I'm not going down that territory this morning, but happy to talk to any of you about that. And certainly you can find all these things on the website of the Center of Excellence for Women's Health. So here's a slide that sort of stretches us to think a bit about gender and treatment. And I want you, as we're going through today, to think about where you sit on this continuum. And really, I'm going to focus on the yellow, green, and blue, on how we can be gender sensitive, how we can be gender specific, and even how we can be gender transformative. In other words, how we can work on gender equity, even as we're offering substance use treatment. And I just want to say, before I start into that, that providing gender responsive treatment is really part of achieving gender equality overall. And this picture here is from a recent report from the United Nations on the Sustainable Development Goals. And it talks about the need for leadership, work, employment, prevention of violence against women, reproductive rights, and gender responsive budgeting if we are to achieve gender equality and empower all women and girls. So I'm going to try and place our work on women and substance use in this context of the larger work on gender equality that's being done internationally. And I underlined the gender responsive budgeting part because I wanted to highlight that I'm going to come back to that for those of you who are health system planners, to think about what all of this means in terms of budgeting in healthcare systems as well. Okay. So let's start by talking about what we mean by gender responsive treatment for women and how we're doing that in Canada already and what's the stretch for us going forth. So this document from the United Nations came out a long time ago, talking about gender responsive programs as those that consider the needs of women in all aspects of their design and delivery, including the location, the staffing, the program development, the program content, and the program materials. And I think that's a really good definition of gender responsive programs. And as they were doing that, they were thinking about how do we create an environment based on safety, respect, and dignity? How do we build relationships, have our policies and practices that are relational? How do we address the issues of substance use along with issues of trauma and mental health through comprehensive and integrated and culturally relevant services? And how do we provide women with opportunities to improve their socioeconomic conditions? And it's interesting, the UN was noticing that back in 2004 when they brought this out, because I think it's a part of women's treatment that we're starting to recognize as more important than ever, that we can't turn women out from substance use treatment into no employment and no housing and all the other determinants that are important. And finally, thinking about how we nest women's treatment into a whole system of community care. Sorry, I didn't realize this was a one by one thing, so the French comes later here. So let's go through these one by one. Let's talk about first what is happening and what could happen around creating an environment based on safety, respect, and dignity in women's treatment. And I think there's been some amazing examples in Canada, including one in this town around the Sophie recovery. This idea of thinking about how we bring in community-based, comprehensive, respectful care. And I just finished this study with some great women from the Nodi Bene Consulting Group called Co-Creating Evidence. And we looked at 8 programs across Canada, one in the Atlantic region and the others in other locations across Canada, that have thought about how to do this work of being non-judgmental and relational and women-centered and bring in all of these principles as we're doing the work. And here's a picture, which is kind of small to see once we've added the 2 languages on the slide. But really, if you think about this picture as a shawl that's wrapping care around women and children, that has all of these elements as part of what these community-based wraparound services offer. So that includes peer support and food and nutrition interventions, support for basic needs, advocacy around housing, advocacy around child welfare and retaining custody, work on substance use issues, work on trauma and violence support, work on all aspects of women's health, prenatal health, children's health, parenting issues, and cultural programming. And we've published a lot of papers around this particular study, but I think it's a shining example of where women's treatment, recovery, and response is going that takes into account the determinants of health. Here's an example of one of the programs from that study, and I'll just pop this all down, given that I didn't realize this was one by one here, but really thinking about how can we provide services that are really welcoming for mothers and children, and that integrate culture at the same time, and look at trauma issues at the same time, and really bring women's perspective to it. So there's peer-driven program development, there's real dedication to engagement around consent to share information, real help with system navigation, etc. So changing the way we do this work from being isolated treatment centers to be nested in community, and really thinking about how do we deliver this in a way that is wraparound, as we call it. So not only do the community-based services start to change around being respectful, so is the work happening in terms of healthcare providers. And healthcare providers are beginning to change the way they talk about substance use in interactions in clinics, etc. And so often in the past, they've talked a lot about this SBIR, screening, brief intervention, and then referral for support by doctors and other healthcare providers. And now we're moving to this idea to starting with brief intervention, then doing screening, and then moving towards support. So moving to a BISR version of it. And what that means is that when healthcare providers begin the discussions around substance use, given the stigma associated with alcohol use and other substances, that they begin by discussing in a non-judgmental and open way. What do you already know about alcohol's effect in pregnancy and in general? And then talking about what we know about that, and then getting to the place of assessing readiness to reduce use and to ask about what kind of follow-up may be needed for each individual woman. So treatment is changing not only in treatment centers, but in everywhere women turn up for support for care. And in no place else is it being better done than in many Indigenous communities across Canada. And I know we're going to talk lots more about that in the next panel. But just to say that many Indigenous communities are doing an amazing job of community-led, community-driven, wellness-oriented approaches that bring culture into recovery in really effective ways. So what have we been doing around changing the environment of women's treatment? We're working on being more welcoming, being non-judgmental, thinking about safety, thinking about accessibility for all women, but especially thinking about accessibility for mothers, and thinking lots about culture as intervention and respecting there are many roads, one journey. So let's go to the second part around relationships. And thinking about how can our programs developing policies, practices that are relational and that promote healthy connections to children, to family, to significant others, and to community. So I've done lots of research with mothers around their challenges and their supports for getting to treatment. And oftentimes they say things like this: we're slipping through the cracks. And when you push and shove and take away the children, I mean, we're losing mothers in droves here, you know. So there's a flaw in the system. And I think it's such a powerful statement of how we need to change to wrap care around mothers and children rather than separating them and making that a barrier for women. I just, and I brought this report with me, just finished this work around mothering and opioids, where we interviewed women around what they wanted service providers to know about mothering and opioids. And they came up with so many great statements like show empathy, not pity, show more compassion and less condescension. Be a support, get behind us, listen and be curious about what might work for each woman, etc. So I feel that experiential wisdom can really guide us in this work going forth. And there are some great programs across the country, like the Breaking the Cycle program in Toronto, that are really thinking about what it is to be relational and to support the mother-child connections. And they have published this great report, which I also brought with me if anybody wants to see it, who's here in the room, around relational practice with mothers with substance use problems. But what's interesting that they've thought about is that it's not only about the relationship between us as treatment providers and mothers, it's about the relationship between the mothers and their children. It's about the relationships amongst staff, the relationships among community agencies supporting women, all grounded in relationship-based theoretical frameworks. So I think it again points back to us as the change, as opposed to focusing only on the women's change. There's lots of work that's been done around supporting parenting and recovery. Some of them, like the Parents Under Pressure program, is delivered in the home to help women with parenting and the fathers in parenting skills where there is substance use in the family. And I think that's a really interesting model of moving out to work in homes. There's also a lot of work to do programs such as Circle of Security, and it's only one of many, that really focus on attachment-based programming that's built into treatment. And supports parent-child relationships for women and their children within treatment, whether that treatment is delivered in the community or whether it's delivered in treatment centers. So studies are going on about what is helpful in that relational practice by counselors in treatment for mothers and children together. And this is one study led by Karen Milligan, Dr. Milligan from Ryerson, what is it called? Toronto University now, around parenting interventions for mothers within treatment programs. And they did focus groups with mothers in 6 treatment programs in Ontario. And the women mentioned what they found most helpful was counselors who practice non-judgment and empathetic listening and supportive commitment to their success. So creating that sense of hope and helping them build emotional regulation. And they also found it was really helpful that counselors simplified their procedures and helped them navigate systems, who reminded them with text messages and offered coaching adapted to their learning styles. So really help them with executive functioning as well as with emotional regulation. So I think it's a good sense for us going forth about what our treatment needs to look like. In the Indigenous world, there's been some great work done by Dr. Colleen Dell and others in Saskatchewan around what women want from their service providers in Indigenous services. And they came up with this wonderful reclaim idea, and there's a fabulous video that goes with it as well called From Stilettos to Moccasins. But they talk about the importance that treatment providers show empathy, acceptance, inspiration, recognition of the impact of trauma, communication, care, attention to spirituality, and this sense of movement, which you also saw in the earlier studies as well, is really helping women have momentum forth on their particular journey. So lots happening in this area of relational practice within treatment, especially as it means connecting and keeping connected mother-child connections. In the co-creating evidence study I mentioned before, with 8 wraparound community-based programs in Canada, this idea of mother-child connection was one of the main reasons why women wanted to come. They wanted to come for help with substance use problems. They wanted to come for that chance to mother and to get support for parenting. They also wanted connection to peers, interestingly enough, and support with housing. No big surprise in Canada these days with housing so challenging. But it's interesting that when programs responded to those things that women said they wanted from the programs and created the environment for that to happen, then that was one of the top 5 most significant changes women made while in the program, was that sense of a strengthened mother-child connection and keeping their children in their care. So, summary about the relational part: we're doing well on starting to really center the perspectives of women with lived and living experience. We're seeing the mother-child relationship as key to recovery. We're seeing the relational stance of the treatment provider as a key aspect of recovery. And we're seeing relational practice in every level of treatment and support. So let's talk about the third thing that the UN felt was really important, which was integrated services that thought about trauma, mental health, and substance use together, rather than saying you come here for substance use only, you go over there for mental health support, you go over there for support on violence issues. And I think, this has become especially important in the context of the COVID pandemic, where we've seen a lot of women worried about their safety. We've seen an increase in alcohol use, and we've seen women reporting worse mental health than men. And we continue to live in a society where one woman or girl is killed every 36 hours in Canada, and that there's still so much need to address violence against women and girls. So we did a study in the context of COVID with the Canadian Centre on Substance Use, with the Justice Institute of BC and Women's Shelters Canada, to think about how could this be happening, that we look at mental health, substance use, and intimate partner violence together. And of course, what we found as one key thing to it is that trauma is at the core of all of those issues, and that really important to see being trauma informed as a uniting paradigm for our work. And so we did see that there was a range of interventions supporting stress reduction and mental wellness in Canada happening during the COVID context. So the mental wellness piece and Wellness Together Canada, the online support that we have, has really helped move us along in thinking about how do we create accessible mental health support, even for people with substance use problems. We saw lots of work on intimate partner violence. We started to see some comfort with initiating collaborative conversations about alcohol and pain relievers, vaping, etc., beginning to happen. That idea in the substance use field that we can be more inclusive when we talk about substance use, and really, brought up the issue of trauma-informed, equity-oriented approaches to integrated support. And I'm happy to say we've gotten some funding from the Public Health Agency of Canada over the next few years to develop models for integrated virtual care on intimate partner violence and substance use issues together. And of course, trauma and mental health concerns will be woven in. But this is something that I think is a real win for all of us in Canada and beyond, where we're beginning to see how important it is to be trauma-informed. And that doesn't mean asking about trauma or treating trauma in the context of substance use services, but thinking about how are we creating safety and trustworthy? How are we collaborating and promoting connection? And how are we building women's skills around self-regulation and all parenting and all these other skills that are connected to being trauma-informed, as opposed to trying to work specifically on being psychologists or psychiatrists or others treating trauma. The folks in Toronto at the Jean Tweed Centre have done an amazing job of thinking about how we can be trauma-informed in women's treatment services. And they give like really concrete ideas about how to bring that about. And I really encourage you, if you're interested in that part of enhancing service, to download this amazing helpful manual around how we can be trauma-informed in women's substance use treatment. We've done some work as well with some of the folks from New Brunswick, as well as other provinces in Canada, around how we can be both gender-informed and trauma-informed together in substance use practice and policy. And our new terrain document talks a lot about how you can multitask like that. So we don't have to think about gender as separate from trauma or separate from other ways of approaching substance use issues. We can fuse and multitask in this work. Just want to give a shout out to Aventa, a women's treatment program in Calgary and Alberta, who have just done an amazing job of linking trauma, gender, mental health, and addiction in their services. And they've really built on the work of Dr. Covington from the US to provide concurrent capable, they call it, trauma-informed and gender-responsive addiction treatment programs to meet the unique needs of women. And they really focus on building trauma awareness, increasing understanding of the connection between trauma, mental health, and addiction, and developing grounding and coping and relapse prevention skills together. So I think, they're a shining example of how it can be done. And they offer that not only in inpatient treatment, but in continuing care, in programs for mothers with FAS, in programs for girls, in outpatient and in live-in services. So lots lots to show that it can be done, and it is being done, and we can all build on this work. Just wanted to come back again to the medical folks who I think are really helping us these days, especially in the context of the opioid crisis, to think about how we bring attention to chronic pain experienced by women and prescribed opioids, and thinking about how we help addiction treatment programs work to include addiction medicine as part of a treatment intervention, as opposed to something that we would consider ongoing enabling or whatever. But really thinking about how do we really attend to the fact that women do experience more chronic pain conditions like fibromyalgia, like endometriosis, many other pain-specific concerns, and are being prescribed opioids for those concerns. And that can be a setup for using more and becoming addicted. So this treatment center that's mentioned on this slide, the Heartwood Treatment Center, is based at BC Women's Hospital, just as my center, the Center of Excellence for Women's Health, is. And they have done an amazing job of bringing in psychiatrists, physicians, and many other nurse practitioners, many other healthcare experts to be co-deliverers of addiction treatment. So, in summary, integrated services are beginning. We're starting to do well at trauma-informed and trauma-specific supports. We are really thinking about how to bring in addiction medicine in both hospital and outpatient clinics. We are thinking about, however, how much more integrated support on substance use and intimate partner violence and sexual assault we still need. And how we still need integrated support for mental health concerns, for sure. And we are really getting to a place with programs like Aventa and others around providing multi-stage supports, networked together in a women-centered and trauma-informed way. And I'll talk more about that in the coming sections. So this unusual piece that we don't normally think about as a key part of addictions treatment was mentioned by the UN, and I think is a really important thing given how we understand the gendered nature of poverty in Canada, that around 1.44 million women are living in low-income families in Canada, and 28% of women-led households in Canada are in core housing need, etc. So these stats from the Canadian Women's Foundation really point to us that we do need to think about how does this affect women's ability to access treatment, to stay in treatment, and to succeed after treatment. I was lucky to do a study in the 3 northern territories in Canada called Repairing the Holes in the Net, that looked at how we could link housing and mental health and substance use and trauma concerns into the work in those territories. And we brought together service providers and policy analysts in virtual communities, and we talked about these things: why gender matters in substance use treatment, how change happens, trauma-informed practice, Indigenous perspectives on mental health, housing first and other housing models, social finance efforts, communities of practice, and mental health and substance use issues amongst homeless and at-risk women. So we had the kind of great conversations that I hope we're going to have here and in many services going forth about how do we do all this work to make it so that this doesn't become the story. This is what a lot of the women and service providers said was happening in the North, that women had unresolved trauma. They had issues of poverty and social exclusion. They had an inability to find and hang on to housing, and the services that were there in the context of helping them weren't always effective at thinking about how these things played together. But the interesting thing for me was, as much as the women mentioned and the service providers mentioned how these things went together and reinforced each other, they also noticed many places around these circles where change could happen. Policies could change so that women could succeed. In transition houses, for instance, that are centered around helping women around violence, they could be funded in a way that allows women to begin starting employment or staying in employment, even as they're accessing violence services, rather than the funding coming in such a way that the house gets funding and women are not allowed to work. So lots of ideas are being thought about and piloted to think about how can we do this work around poverty and employment and housing, even as we're offering substance use and violence services. And in my town, in Victoria, BC, there's a great program called Bridges for Women's Society. And it's basically a program that supports women on finding and getting employment and other socioeconomic ways of issues. And really, in the middle of that, provides trauma-informed counseling and healing as they're doing these pre-employment programs. So lots of work to cross the issues so that treatment can be really linked to community-based vocational support. The Caris Support Society in Kelowna has really thought a lot about having programs at 3 stages, very much like Aventa in Calgary, that they offer programs to support and empower women in the early stages of recovery, in stabilization, and then they continue support into semi-independent living in a safe housing program and provide aftercare programs to support women to create connections and support into the community. So they transition into safe, independent living in the greater community. So people are thinking and doing this kind of work. It is doable. And in summary for this section, I think I just wanted to quote this piece from the Substance Abuse and Mental Health Services in the US in this document called Changing Communities, Changing Lives. They say trauma-informed care is as much about social justice as it is about healing. And I think we could say the same thing about substance use services overall. It's as much about social justice as it is about healing and recovering. So the last part about community collaboration, I think, is a really important part about how we achieve that. And in my town, again, in Victoria, the Victoria Sexual Assault Center has worked with the addictions field to offer integrated program that's based on the Seeking Safety model by Dr. Najovitz in the US. But they started the program in a way that I think is really helpful and that all of us could integrate by offering sessions that are just drop-in sessions where women learn coping strategies and just get comfortable with coming to a service and getting some skills around staying calm and being ready to look at issues. And then they offered the Seeking Understanding group, which was a 12-session group that's really looked at topics related to trauma and substance use, co-facilitated by a sexual assault counselor and an addiction counselor. But I think the interesting part for me, and that many women mentioned was really important to them, that even though it was a 12-session group, they offered 6 sessions. And then they gave women a choice about whether they wanted to do the second 6 sessions right then, or whether they wanted to stop and you know, think through and practice the things that they'd thought about in those 6 sessions before going on and finishing the second group of sessions. And so, you know what the outcome was? The more women succeeded. Right? Because instead of dropping out when they were overwhelmed partway through, they actually got the chance to stop and integrate and then pick it up again without being judged for that. And some of the women even just went to the safe coping strategies part and said, I don't want your group. I'm just happy to take this. Thanks very much. And I think, you know, that's the kind of collaboration and choice-oriented work that we can build into our systems of care really easily. In this work on mothering and opioids that we've done, we actually mapped with the child welfare system what was their work, what was our work in the addiction field, and what was our work together. And so on this slide, you can see that the substance use people were supporting recovery and reducing harms. The child welfare people were supporting families to stay together and trying to keep children safe. And in the center, they had some really common things of supporting attachment and parenting and supporting the social and material needs of women, and a lot of shared approaches down at the bottom about mother-child togetherness, the involvement of mothers, trauma-informed, being optimistic, etc. So I just think it's, you know, it is doable and kind of fun when you honor what other systems of care have as their mandates and think through, well, where's the collaboration point? Not trying to suggest that all mothers will be able to keep their kids, but just thinking about what is our work to be able to support child welfare, even as we're delivering women's treatment. Now, this will make you crazy, especially in the small towns, but this is a tool within the Mothering and Opioids book that just points out that there are a lot of different services where you might do that collaboration work. It could be in prenatal services. And I know we're going to talk about social pediatrics tomorrow, and I think that's a key place of connection with those services, with food services, with exercise services and community drop-in physical health places, lots of different spots, violence services, etc. So, you know, when we're thinking about how you do that collaboration, it doesn't have to be only with child welfare. It could be with any number of services that where we make that sense of here's what we're doing, here's what you're doing, and here's how we can make it work together. I just wanted to mention this treatment center in Saskatchewan, and I know that Portage has been interested in this area as well, of thinking about building treatment centers where women can bring their children with them. And I think that's a really important part. And this group in Saskatchewan, the Family Treatment Center in Prince Albert, does support that. Women come with their children. But again, like many other places, they've really noticed that, yes, that happens for a period of time. We offer programs for the kids. We offer schooling for the kids. We support the mothers. We have elders and other Indigenous folks helping with a cultural aspect of the program. But we have to think about where the women are going afterwards and how we're building aftercare supports that help them with housing, with custody, with all the other employment, vocational needs as well. And they've been really doing a great job of building connections with Indigenous service providers throughout northern Saskatchewan and helping make that transition to a person who is understanding of women's treatment as they leave. And in the urban areas, lots of thinking about how to build a perinatal substance use continuum in BC. And this is a blueprint that has been created there that again comes back to these principles we've been talking about this morning. Mother and baby together, trauma-informed, Indigenous cultural safety, harm reduction linked to recovery, women-centered, recovery-oriented, interdisciplinary, evidence-informed, equitable access, etc., all built in to try and build a system that is thinking in these ways. So I just want to end this part of this section, and I'm almost at the end in general, by talking a little bit about this linkage between harm reduction services and treatment services, because I think it's one of our most important challenges in women's treatment and in treatment in general. And I wanted to point out this little graph kind of thing that we put together many years ago in BC, where we thought about what we need in the substance use field are services that are oriented around stabilization and saving lives in harm reduction. So saving lives services, stabilization services, healing services, and then the reconnection to community services. And often in the past, when we've talked about women's treatment, we've thought only about that circle at the bottom, live-in treatment and community treatment that's in the healing part. But I think now we're at the place of really understanding how we need to connect to the harm reduction part of the continuum, as well as the aftercare part, and spend more time thinking about that collaboration there. The other thing that I think was interesting as we looked at this, continuum, or at this matrix model of what do we need to support people with substance use problems, we also recognize that even amongst those different areas of harm reduction and healing and reconnection, we also needed to think about the people who weren't ready to access those services, as well as those who were thinking about it and those who were ready. And I think that's a really important part, because you offer different services to respond to those needs, and you recognize that we have to pull all these together if we're going to end the opioid crisis and our response to it, and many other harms related to substance use, and to offer more responsive treatment, gender and informed and otherwise. That picture in the center is of a women's overdose prevention site in Vancouver. That's the only one I know of in Canada that is trying to do that thing of creating safety for women, looking at issues of violence and connection and peer support, even as they're very much up in that harm reduction, saving lives, not necessarily necessarily ready to change part of this continuum, but recognizing that we need to be women-centered and gender-informed everywhere in this continuum. So, couple more slides around where are we and where are we going? I think that the territory of gender-informed treatment for women that was mapped by the UN back in 2008 remains relevant. We need to think about the environments of our services. We need to think about supporting relational practice. We need to think about integrated mental health, substance use, and violence services. We need to think about socioeconomic issues for women who have substance use problems. And we need to think about community collaboration. And some of that we're doing really well. And I think we need to continue to bring attention to the need for respectful, accessible support and treatment for pregnant women and mothers, and bringing attention to women's perspectives on what works for them and their strengths and reduce stigma. We need to continue building understanding and action on trauma and substance use links. And we need to continue and build on the need for a continuum of support, from harm reduction to treatment to ongoing support on housing and parenting and vocational needs. But we also have some additional actions that we could sure benefit from. And I think, you know, that work around violence against women and girls as a key determinant of women's health, and to be thinking about what does co-development and provision of integrated services that address violence against women and girls and their substance use together. And in the context of the unsafe drug supply, I think more attention is really needed to chronic pain experienced by women and prescribed opioids as a pathway to addiction, and the need for integrated mental health, physical health, and substance use response. And a whole bunch more services are needed for women with substance use problems. We need a visible, respectful, comprehensive, gender-informed continuum of support and treatment, involving and funded by multiple government departments, both community-based treatment and virtually based, as well as live-in. And I think the minister last night spent a really great amount of time talking about that idea that it's more than one place in government that will be a part of funding such actions. So to come back to that piece around the funders and the health system planners, and that idea that the UN has put forth so recently around gender responsive budgeting as a part of the work to achieve women's equality across the world. I think we need to think about gender responsive budgeting applied to the substance use field to ensure a continuum of services is available for women using these principles that I've talked about throughout the presentation today. So I hope that that has been a great, helpful journey to talking about gender responsive treatment for women. I hope you recognize how complex it is and are ready for taking it on and not looking for simple solutions, but really thinking about all the ways in which we can improve care. And I would love to stay connected to all of you who want to be connected to the ongoing work around women's treatment in Canada. And I and others at the Center of Excellence for Women's Health are really pulling together communities of practice amongst clinicians who are working in this area, who want to share stories and take strength from each other. And I really hope that some of you will think about how about staying connected and keeping on discussing how we can be gender responsive in women's treatment. Thank you.
Is this on? Yes. Okay. So now we have time. First, before we go to the Q&A, we have a Q&A planned. I would like to acknowledge the presence of the Honorable Minister of Tourism, Heritage and Culture, Tammy Scott Wallace, who has joined us. Thank you very much for making time to be here today. If I'm not mistaken, the Cassidy Lake Center is also in your riding. Yes. So we have an amazing champion in the room with us today. Thank you very much. It's really exciting that we have some strong policymakers here with us today. So yeah, we have our break is scheduled for 10 o'clock and we've set aside some time, if you're okay with that, for a Q&A. So the way the Q&A is going to work, we are going to open the Q&A to our virtual participants first. So Tammy is going to be monitoring our Zoom link for questions. And as those questions come in, we're going to try to address them first. And hopefully the virtual participants can hear me say this and start firing questions. And then I'm going to ask people in the room if you have questions as well. If you have a question, please raise your hand. I'll try to make sure I go on a first come, first hand, first serve basis, and then I'll invite you to come up to a microphone and ask your question to Dr. Poole. Does that work for everyone? Okay. That was a wonderful presentation. Yeah. Okay, so I don't see any questions coming in yet. Tammy's going to keep her eye on that. So I'll invite anyone from the room. If you have any questions, please raise your hand.
Or comments.
Or yeah, thoughts on your own work in relation to the material and the work that we've received information about. Yes. Peter.
Cool. Thank you very much. Can you hear me?
Yes, yeah.
It's a very lucid and informative talk. And my question is quite simple. It's from your perspective of 20 years, concerning yourself with gender-informed treatment. Are we winning or losing? I'm paraphrasing Dr. King's often asked questions when we're debating how to advance matters. You made a number of comments which gave us a sense of the pattern, a sense of the progress that's being made. But we, Portage, work on a daily basis with the challenges addressing the challenges that you've mentioned. And sometimes it's difficult to decide whether we're winning or losing.
I totally understand that comment and question. And, you know, I think it's like I mentioned in terms of what the women wanted from their service providers. Both in the Indigenous women in the reclaim principles and in the parenting programs, is they wanted service providers that had a sense of hope and had a sense of optimism and had a sense of helping them progress, even if it wasn't 0 to 100, that even if they could help them progress from 0 to 10 and then to 11 and then to 12, etc. So I think that we are really challenged to be optimistic in that way and to feel like we are winning, given how few women's treatment centers there are. And given how big the issue is, whether it be alcohol or cannabis or methamphetamines or opioids, etc., I feel like we're standing here trying to, you know, turn the Queen Mary around as a little tugboat kind of thing. And it's challenging and it's complex and it's really important that we see ourselves as winning and taking steps forward, even if, you know, it often feels like it's a hard journey. I think it behooves us to be optimistic in that way. And it was interesting. One of the studies I did a long time ago when I first started to research substance use as opposed to being a provider and a user, I did a study on what were the barriers to treatment for women who were accessing both treatment services, but also detox and also pregnancy outreach programs, et cetera. And it was interesting. I decided to ask the question from what are the, what's prevented you from getting here as fast as you might have, but also what supported you to get here. And it was interesting because I asked the question that way, instead of being another study of all the things that are problems, it ended up being a study that gave people a lot of ideas about what they might do. Right. So that's why I tried to focus the story a bit this morning on that idea that we are doing things and we can do things. And in the case of that study, it was interesting that what do you think was the top support that women mentioned that got them there? It was a service provider. It was a service provider in a friendship center, in an outpatient medical clinic. It was in an e-fry community center. It was somebody somewhere said, gee, it looks like you're in trouble. And could I help you get connected to treatment? And that is what made the difference. And I think that for me, that's the side I always like to look at, is the glass half full, and that idea that it only takes us to start talking about substance use, acting on substance use, to make the conversation open so that women will feel like if they come for care, that they will be treated with respect. They won't automatically lose their children, that they will have the capacity to grow and change with lots of support. And I think that's just critical to us moving forth, is changing that idea that if you use substances, you're somehow lesser of a person and you don't deserve to parent. If we can change that and really help people feel that it's possible to recover and there's support for recovery. And I think that's the second half of it that Portage does so well, and many other services as well, is that the battle is partly in helping everyone feel like recovery is possible, and there are supports for it, but there also have to be those supports. And I feel like today I have mentioned in this thing almost every women's treatment center that I know of in Canada. There's not that many gender-specific treatment programs in Canada. And I think that's the challenge we have, is to really get that gender responsive budgeting happening so that we see how we can build upon the system of the great services like the one here in Sophie House, that we just need to keep making available this support, so and make it visible, accessible, and respectful. And I know that Portage has been really critical on that. We need lots more of you in lots more locations across Canada, and many other providers need to be able to expand on the work that they're doing too. And it's not only creating new services, but it's helping the services that are already out there in communities do their part. And that's why I spent so much time on collaboration, because I feel like that's where the change can happen. If you go into a service around violence against women, instead of people saying, you can't come here if you use substances, they can come to a place of understanding. Of course, she's going to be using substances. It's so common that substances are used to cope. And therefore, what can we do in collaboration with our addiction counseling friends or in general to make it possible for her to reduce her use and benefit from the care we have here, keep it safe for kids in the house, etc., even as we're making our services available. So instead of a whole bunch of new services, it's also about everybody taking up the challenge and being part of the change. Yeah.
Am I on?
You can tell I'm not a short answer person, sorry.
No, that's perfect. So we have two questions here, and they both sort of build on that point, Dr. Poole. So in the chat, there's a question. So the idea is that we need to make more of a one-stop shop to meet the needs of women and children. And then the other piece to that that I'd like you to consider when answering that question, I think all of us here in attendance today are selfishly here, and we want to take back the information and the conversations that we have to our own respectful communities at home.
Yeah.
So when you are talking about these amazing programs offered at a national level, what is your advice to people here going home that don't have access to one of these fantastic centers in their city? So to a smaller community or to a smaller city that probably has women's shelters and women's groups, but how do we help our communities on a practical level going home today? And
Well,
that's a really big question, I
It's
know.
a big question, but one of the programs in the national study I did around the wraparound services was a family resource center, which you have in this area. And I guess what I find is that yes, there are the one-stop places in urban centers where there's a critical mass of substance using pregnant women needing to access that. But in most places, those services are not offered in one stop. They're offered in one network, right? So it behooves us wherever we are to find anybody doing something that is connected to women's health. And that could be the local doctor, or it could be the prenatal program or the Lamaze program. It could be anything that is anybody who is working with women anywhere in the community, and building that kind of network to say, let's think about how we collaborate and figure out what we can do together. And so really, I know some of this sounded fancy, that, being done in big cities, but most of the work is being done in small places without formal treatment centers, etc. And I think that idea of us listening to women about what they need and building focus groups that, in our communities to say, well, how could we make it better? What about a Monday afternoon walking group, where women with substance use programs or substance use issues come together and walk, right? It's a health promotion thing, and it's a place of peer connection and support, and it doesn't cost anything, right? And it benefits all of us. And maybe in the course of that walk, some women will mention, gee, there's a great nurse at the local clinic, and she really helped me start to think about how much alcohol I was drinking. And, it might be, I really recommend if you're thinking about, reducing your alcohol use, she might be a place to start. Right. So I just feel tremendously optimistic that we can do this wherever we are. But it does mean that we change, that we commit to the change.
Mhm.
We've asked so many years for women, stop using, get better, et cetera. It's on you, but it's not on them. It's on us to
Mhm.
be the part of the change and walk with and guide the change, rather than being that sort of, I know what you need to do. You need to go to this many, support groups. You need to do this, you need to do that. And it's not relevant to what she feels she can do. So if we can turn it around and listen, to listen to your friend about her challenges, right? And think about what might have happened if anybody along the way had said, geez, come along here with us, and I think that's the challenge we have. And it's so doable. That part of it is so doable. But it does mean that we do things like you have done today, of coming and thinking it through together and learning more about the substances and the services available. It's a bit of work on our part, that's for sure.
I think that builds on, for those in attendance last evening, to Minister Shepherd's message. Would you say about, we're guilty of working in silos
Yeah.
for so many years, and that this really is a community issue. The ownership isn't on that individual or that individual's family, but we need to have conversations together, be it in government, be it in service providers and between service providers.
Yeah.
Today.
And even amongst employers as well, of thinking
Absolutely.
about people who could take on a woman who can only work part-time because she's still parenting and she's still in recovery, but she could use the opportunity to begin the steps forward and hold her in the system rather than on social assistance forever, right?
What I'm hearing is a big theme in your presentation as well is conversations, and conversations here, but conversations out in society and in our communities and with government. I sort of have a loaded question for you, and builds on Mr. Howlett's comment about winning or losing. Would you say that we are addressing the issue? Do you think there's a lack of education, or do you think there's more knowledge that needs to happen within the
Absolutely.
communities?
Absolutely. And
And how do we do that?
I feel a bit hopeful about that because we just had September 9th, which was International Fetal Alcohol Spectrum Disorder Awareness Day. And I was blown away this year by how many communities across Canada got on side and did something, a walk or a booth or something. They lit up landmarks. They did all manner of things. And I feel like this is a point where the tide is turning, and we have social media and so many other ways now of texting and connecting people up on these issues, that I think the conversation is ripe for happening, and on even really difficult issues like prevention of fetal alcohol spectrum disorder. So I'm hopeful.
Actually, it is 10 o'clock, but I always say a sign of an incredibly engaging presenter is that you're running over time. The questions are made. So what I'm going to propose, if everything's okay, everyone's okay with that, is that we do break, but do you want to still continue taking questions? Maybe come up and ask your question to Dr. Poole, or we will.
I think we'll have time.
Yeah, and we might have time during the next session to do some catch up as well. Just so we stick to the program, but we leave, some room open maybe in the next session to ask those questions, if that's okay. That works. Oh.
Yeah. Yeah.
And then break?
Yes.
Okay, go ahead.
Thank you. I'll try to be quick.
Oh, that's okay.
I'll try hard, but I don't know if I succeed. I don't know really if this is a question. Well, first of all, a comment. I really appreciate the thoughtful work that you obviously have been doing and that you've presented here so eloquently. Yeah, I'm a frontline worker. I'm a physician with an addiction practice in Kingston. So of course I sit here listening to you talk about this and I think, yeah, but like I'm trying to imagine all these scenarios, seeing women in front of me dealing with substance use in pregnancy, thinking, but how does this relate to, how would I ever bring that up to them? And imagining the rolled eyes and the scoffing and sometimes frankly contempt that one gets when one thinks one is being gender sensitive. Just an example, it's a little bit, it's ridiculous to talk about it as backlash, because backlash generally happens after there's been some movement forward. And I'm just so aware of how little movement forward there has been in gender and equity for women and people who are differently gendered. But for example, in our hospital in Kingston, the clinic that used to provide family planning and abortion services was called the Women's Clinic. And because of the professor of gynecology who works in the clinic and does gender reassignment surgery, she pointed out, look, we shouldn't call this the Women's Clinic. We should change it to something that's non-binary. And so there was a decision made to do that. But the reaction among the mostly female staff who work in the clinic was so bitter and negative. They felt attacked, and they felt that this was somehow an act of disrespect against women because the word woman was taken out of the clinic name. So the very thing that was being done to try to demonstrate, to perform gender inclusivity and sensitivity to non-binary people was taken by the female staff as being somehow disrespectful and undermining of women. So I would just be curious to hear about, and I'm sure you're very well aware of how people backlash, the backlash against this. I'm just curious to hear your comments.
It's a really important issue, and we could take hours to talk about it, and I'd love to talk about it in more detail. But suffice to say, I do not think we can lose the word women. We can add women and gender diverse clinic, or but erasing the word women is not going to help women feel like there are visible and supportive services available to them. So we have to find a way of, not being gender neutral, but being gender additive and gender inclusive. And I think that's the challenge we have in front of us. That's an important one. And what's so great is that idea, the gender story expanding, I really support, because it is addressing that idea that gender norms and gender stereotypes need to change if we're going to move forward. We need to get out of these rigid roles where mothers are looked at as problematic if they use substances, but not fathers, right, etc. So there's lots of things we need to change, but I don't think erasing the word women is the way forward. So that's the short answer, but I've got a much longer one as well.
Yeah. Okay, so excellent questions. So we are going to go to a nutrition break right now and reconvene at 10:30, which is the start of our next panel. Thank you so much, Dr.
Thank you.
Poole. Thank you. Okay. 20 minutes, that's good.
Don't wanna spend my whole life catching my breath, 'cause I've been running round and round and round, and I got nothing left. There's nothing like a sunset skyline to let you know you're almost home. So breathe in and hold tight. I'm coming home tonight. Meet me in the valley where the kids collide into the morning. Oh my God, my town is coming
There's something in the way you roll your eyes. Takes me back to a better time when I saw everything is good. But now you're the only thing that's good. Trying to stand up on my own 2 feet. This conversation ain't coming easily. And darling, I know it's getting late. So what do you say we leave this place? Walk me home in the dead of night. I can't be alone with all that's on my mind. So say you'll stay with me tonight. 'Cause there is so much wrong going on outside. There's something in the way I wanna cry that makes me think we'll make it out alive. So come on and show me how we're good. I think that we could do some good. Walk me home in the dead of night. I can't be alone with all that's on my mind.
1, 2, check 1, 2.
So say you'll stay with
Checking,
me
testing.
tonight. 'Cause there is so much wrong going on outside.
Checking and testing. Checking and testing. Test 1, 2. Test 1, 2. Checking and testing. Test.
Walk me home in the dead of night. 'Cause I can't be alone with all that's on my mind. Say you'll stay with me tonight. 'Cause there is so much wrong going on. Walk me home in the dead of night. I can't be alone with all that's on my mind. So say you'll stay with me tonight. 'Cause there is so much wrong. There is so much wrong. There is so much wrong going on outside.
And the lights are out, you stumble in the dark. You kept pushing on, but then you went too far. When your ship has sailed and all your dreams are lost, everything is wrong, you feel like it's your fault. Just remember, I will be there for you, baby. Remember, there's nothing out there to get you, don't forget it. When life throws lemons, just call on me to get you, don't forget to get you, to get you, don't forget to get you, to get you, don't forget Just let me know and I will just call on me. Watching these days turn into night, and lately my hands don't feel like mine. Oh, my eyes keep blurring these lines. It's like I've been wasting precious time, sleeping at the wheel. I know there's so much more to feel. So come on, love, wake me up to something real. If I'm just sleeping at the wheel, if I'm just sleeping at the wheel. Got air in my lungs that I can't breathe, and blood in my veins that I can't bleed. And I'm just trying to revive what I believe, running in circles round these streets, sleeping at the wheel. I know there's so much more to feel. So come on, love, wake me up to something real. If I'm just sleeping at the wheel, if I'm just sleeping at the wheel. Tell me everything will be okay. Yeah. Tell me everything will be okay. I wanna feel this all the way. Tell me everything will be okay. Sleeping at the wheel. I know there's so much more to feel. So wake me up to something real. If I'm just sleeping at the wheel, if I'm just sleeping at the wheel. Tell me everything will be okay. Yeah. Tell me everything will be okay. I wanna feel this all the way. Tell me everything will be okay.
Hello, Christine. You're muted. Hello. Nice to meet you. We haven't met before.
Okay. Hi.
We haven't met before.
No.
No. I've been to Canada a couple of times.
Where are you from?
I'm from Sweden, but I belong to the Soviet Union.
Okay, okay.
Yes. So you and I will hold this seminar. So it's only you and I.
Yeah, I didn't make it to the conference. I got stuck in Montreal because of the hurricane.
It's hard to hear. It's so much pop music.
Yeah, I can hardly hear.
to get to you, to get to you. I put my love in every stranger, took too much easy anger off of you, yeah, off of you. I've been running through the jungle, I've been crying with the wolves to get to you, to get to you, to get to you.
Just a quick reminder, we will reconvene in 5 minutes. Dans 5 minutes, on reprend pour le prochain panel. Alors, juste un petit coucou, il reste 5 minutes dans la pause. 5 minutes left.
This is what we're waiting for. And in my mind, in my head, this is where we all came from. The dreams we had, the love we shared. This is what we're waiting for. In my mind, in my head, this is where we all belong. In my mind, in my head, this is where we all belong. In my mind, in my head, this is where we all came from. The dreams we had, the love we shared. This is what we're waiting for. In my mind, in my head, this is where we all belong. In my mind, in my head, this is where we all belong. And in my mind, in my head, this is where we all came from. The dreams we had, the love we shared. This is what we're waiting for. And in my mind, in my head, this is where we all came from. The dreams we had, the love we shared. This is what we're waiting for. In my mind, in my head, is where we all belong. In my mind, in my head, is where we all belong. In my mind, in my head, this is where we all came from. The dreams we had, the love we shared. This is what we're waiting for. In my mind, in my head, is where we all belong. In my mind, in my head, is where we all belong. In my mind, in my head, is where we all belong. In my mind, in my head, is where we all belong. Havana, ooh, na, na. Half of my heart is in Havana, ooh, na, na. He took me back to East Atlanta, na, na, na. All of my heart is in Havana. There's something about his manners. Havana, ooh, na, na. He didn't walk up with that, how you doing? When he came in, he said there's a lot of girls I can do it, but I can't without doing forever in a minute. That's on my night. And Papa says he got Milo in him. He got me feeling like ooh. I knew it when I met him. I loved him when I left him. Got me feeling like ooh. And then I had to tell him I had to go. Oh na 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 na. Havana, ooh, na na. Half of my heart is in Havana, ooh, na na. He took me back to East Atlanta, na na na. All of my heart is in Havana. My heart is in Havana, Havana, ooh, na na.
Jeffrey, just graduated fresh on campus. Fresh out East Atlanta with no mountains down. Fresh out East Atlanta, up on board like a traffic jam. Man, I was quick to pay that girl like like Uncle Sam. Here you go, hey, take it on me. Hey, try to crave it on me, get the eating on me. She waited on me, damn. Try to cake it on me, got the bacon on me. This is history and I'm making on me. Point blank, close range, that feed. If it goes a million, that's me. I was getting moolah, baby.
Havana, ooh, na, na. Half of my heart is in Havana, ooh, na, na. He took me back to East Atlanta, na, na, na. All of my heart is in Havana. My heart is in Havana. Havana, ooh, na, na. Take me back, back, back. Take me back, back, back. Take me back, back, back. Take me back, back, Havana, ooh, na, na. Half of my heart is in Havana, ooh, na, na. He took me back to East Atlanta, na, na, na. All of my heart is in Havana. My heart is in Havana. Havana, ooh, na, na. Havana, ooh, na, na. Falling into you, baby. Even electricity can't compare to what I feel when I'm with you. Oh, baby. Giving up my ghost for you. Now I'm see through. You give me
OK, je vais inviter tout le monde à reprendre leur table, leur siège. I invite everyone to return to their tables. We're going to go to the next part of our presentations this morning. So I'm going to hand the mic over to Tammy. Tammy is one of my partners in crime this weekend, and she's going to talk about our next panel. Thank you, Tammy.
Good morning, bonjour à tout le monde. It's great to be here and gather all together. Kathy asked that I introduce myself. So my name is Tammy Johnson. I'm a nurse in Moncton. I specialize in multiple sclerosis and not addiction. I am not an expert in that field at all. However, with that, I do have personal experience. So I'm not here representing Horizon Health. I'm here in a volunteer capacity, just so you're all aware of that. I became involved with Portage, sadly, but also very fortunately, 5 years ago. I'm married to a beautiful man, Dan, and we've raised together 2 beautiful boys. And sadly, our youngest became different. Christmas of 2017 was just a weird Christmas, and call it a mom's intuition, but there was just something that wasn't right that Christmas. And I chalked it all up to, it's just a teenager. It's just a boy going through his stuff. And in January, it became evident there was something more to it than that. February, I can't even remember exactly, but that's when I knew that something was terribly wrong. And only about a week and a half later, I got a call from the principal at school saying that he was suspended because he had punched a boy in the face. And I say that laughingly, jokingly, it's not funny, but it's totally out of character for my boy to do that. And so that day affirmed to me that he was using drugs. I knew it. Other people tried to convince me that that wasn't the case and sweep it sort of under the rug, or she's just going through an awkward time, including our own family doctor. So I guess my point to this is the months that ensued after that day and the days that ensued that, the feelings of fear, and fear is an understatement when you're a mom and that's your child, or you're a woman and you have a child, or any person is an understatement. I was terrified. Never in my life had I felt so lonely, ashamed, and isolated. We didn't talk to anybody. We just sort of locked ourselves in our home and just tried to figure things out on our own. So I am quite resourceful. And if you speak to my colleagues at work, you'll know that I can be a dog with a bone on a personal level. When I sink my hooks into something that I believe is important and to advocate, I do that all the way. And I'm happily doing that in my role as an MS clinic resource nurse. And I certainly did that with my beautiful boy. We took him for a tour to Portage after many phone calls and conversations in hopes that he would agree to go and enroll in that program. And he wasn't ready that day. And there was nothing that we could do about it because he was of age. And so we went home and did what we could in the School of Hard Knocks. And last night I heard the term from a very interesting young woman that I met from Ontario, that she weaves a spider web in her program. And I thought, oh my God, I love that acronym. And I think in all of the talks that are going to ensue over the next 2 days, I think that spiderweb theme can summarize it all. So I started backwards in my journey with Portage because my son was having nothing to do with it. So I went backwards and started in their aftercare program as a parent support group. And it was that parent support group that gave me the education, the love, the feeling of belonging, broke down some of that shame and some of those barriers for me to help me love and parent my son the way that he needed me to do so that he would access care finally. And so for that, I am forever grateful. In with all those emotions was an overwhelming sense of hopelessness. And so as we move forward through the next couple of days, I think that hopelessness word is going to resonate with me. A brilliant young woman by the name of Amber Parlee told me, Tammy, as I cried and was hysterical some nights, not knowing where my son was at the time. It's a positive from a negative, Tam. You have to look at the positive from the negative. There's always a positive in the negative. But I didn't see that for a very, very long time because of the overwhelming sense of hopelessness. And I think that some people in many of our communities are feeling that as we look at homelessness and drug use and the crisis that is coming to be our reality now. And so I was able to learn from this young, brilliant Amber, and hope has become my new word. And it became my new word as I wondered where my son was one night when he had run away during his addiction. And I changed the locks on the door and entered a new security code for the garage door. And the code was hope. Because I thought if I lose hope, it's over. I've lost my boy. And so as we move forward this week, these next couple of days rather, when you Google the word hope, it sounds like a very lame sort of term, hope. Well, we all hope. Sure, we can hope. And it sounds a bit empty, but I think it's just the opposite. And so as we listen to all of these brilliant presenters over the next 2 days, I'd like for you to think of the word hope as we move forward and we go home. And with the word hope comes an expectation. And I think when I leave here today and tomorrow and Saturday, I'm going to expect more of myself and more of our community. I think we need to do that because this isn't an individual problem. And we need to put that expectation on our peers and our coworkers in everywhere that we are and what we do and where we work. We have to put that onus on a community. with hope comes a belief. I believe that we can work on this, that we can win this, that we won't lose this battle. And it may be a never-ending one, but we need to have that belief. And the other word that comes up when you Google it is awaiting and anticipating. And so I think with some of the things that we're going to learn from each other here in the next 2 days, that we can await for change to happen. It will come, but it's not going to be easy, as Dr. Poole alluded to. So as we weave the spider web over the next couple of days together, and we increase our expectations of each other and our communities, I really hope that we will win at the end of the day. And I really think that we can do that together. So thank you for all being here. I think as well, when we look at the speakers that are here, it is very evident when we talked about silos and working in silos, that it really is holistic care that is going to help us win this in the end, because we can't do it individually or within our own private groups of employment. So I'm very grateful to have been through what we've been through, my husband and I, and my son, who is actually doing very well, I'm proud to say today, going to school and thriving and living a wonderful, happy life. And as are we. But I am changed, and as is he. And I think that everybody who knows and loves our family is as well, because I have made it my focus to be open and transparent and honest and real. I was so arrogant at the beginning of our journey, and ignorant and arrogant, I think, would be the two words, because I thought that we had done everything by the book, the right way, that would not ever happen to our boy or our family. I learned in family group as I looked around that addiction does not discriminate. And so I think that that message we need to also relay to the people in our communities, to our friends, and start those conversations, and that very basic education needs to continue if we're going to truly win this battle. So without further ado, let us move on to the Indigenous panel. I am very excited to hear what our next speaker, Miss Ella Karen Blind, is going to discuss. She is an elder Indigenous woman that is from Sweden. So she's going to be joining us via Zoom. She wasn't able to come in person, obviously, from Sweden. She is a member with a non-government agency looking after the Sami people. It just astounds me that she represents so many people from Finland, Norway, Sweden, and Russia, and that she talks about the rights and interests of these 4 countries and the Sami people where they live. And so I think we're all going to learn a lot of excellent things from her in this presentation. She's a cultural advocate, I think, in every sense of the word. Christine Petawabano is also going to be joining us via Zoom. Sadly, she was at the airport and her flight was canceled, thanks to Miss Fiona. So Christine is going to be joining us via Zoom. Christine is a community leader, I think is what I would call her when I look at her bio, or when you look at her bio. She is celebrating 13 years of her own sobriety and conducts annual well-briety retreats in her community where they celebrate each other living a life in wellness without drugs and alcohol. She loves celebrating the land. She's a 4th-year sun dancer and spends as much time outside in her exercising and participating in traditional wellness lifestyles, but also attributes that to helping her stay healthy and well in her journey. She also has been a volunteer for years with the Mistini Hope Committee, which celebrates and recognizes sobriety in their community. Imelda Purley, you will note, is also on your agenda and in your schedule due to a family emergency. She has had to withdraw from today's presentation. We are sorry that Elder Purley, will not be able to join, as is Lisa Copperqualic. She is also on your agenda and has had to withdraw today. So without further ado, let's link in our speaker, Ella Karen Blind, please. And Dr. Poole, she's going to join as well. She's graciously agreed to also discuss her work that she's done with Indigenous women and as it relates to her programs and where she works as well. So I invite her to join me on the stage. I don't like to sit up here alone. Thank you. So she will also be participating in this panel. So thank you and enjoy. Do we have Ella Karen Blind on the line on the Zoom?
Yes,
Oh,
I'm
there
here.
she
Yeah.
is. Hello, good morning.
Yeah. Good afternoon. It's 4 p.m. here in Sweden.
Oh, thank you so much. Thank you so much. Without further ado, the mic is all yours.
Yes, and I have a PowerPoint, so I will talk about Sami culture, and there is someone who will help me with this PowerPoint. Yes, there it is. Poribiaivi Puokkaide. My name in the Sami language is Mikael Pieraristina Marke Elekaren. And I'm a Sami, elder Sami woman from Samiland in Sweden. And I will just give a quick overview over the Sami people. As we heard earlier, we are one people in 4 countries: Sweden, Finland, Norway, and Russia. And I'm coming from a reindeer herder family. My brother, he's got reindeer, and I also got reindeer myself that my brother is taking care of. And here's a picture of me when I was small and taking care of the reindeer calves in the corral. Next slide, please. Yes, and we are indigenous people in Scandinavia and in Russia, and I will just give you a short overview how many we are. And you can see this is the map we have over the Samiland, and you can see it's upside down. Is it? We have the north in the red mark you can see here, and we have Sami parliament in both Finland, Norway, and Sweden, but not in Russia yet. Yeah, next slide, please. Yeah, this is our land, Sápmi, Samiland, and we live, as I said before, in 4 countries. We were here before the national borders came. Next slide, please. And who are the Sami people? We can point at, yes, there you are. And we don't have any ethnical register in Sweden, not in Norway either. So if you feel that you are a Sami, no one can argue about it and saying you are not. But if you want to vote for the Sami parliament, you need to be registered to be able to vote for the Sami politicians' parties. Is it? Next slide, please. And we have our annual meeting, and here we can see, I just want to show you the different Sami dresses that we have. And the Sami dresses, it's a way of showing your own culture, where we come from, and you have different Sami dresses depending from which area you are from. And I come from the northern part of Sweden, but my parents and my grandparents, they were forced to move to the southern part of, to the middle part of Sweden, because the Norway closed the border So we were not able to stay there any longer with the reindeers. So we have to move down south. Next slide. And here is just a map over the Sami villages in Sweden. You have to belong to a Sami village to be able to be a reindeer herder. Next slide. And we also have official symbols. We have a Sami flag, a national anthem, and we have a Sami National Day. And so we celebrated the 6th of February in all the 4 countries in different ways. So you are also invited to celebrate the New Brunswick, Canada. So I can send you a Sami flag if you want. Next slide. And we also have this Sami Parliament. And this Sami Parliament, they have a board, a health board, but they don't have so much money, and they haven't are working with this alcohol and drugs questions. I haven't seen that, so I will return to that. Next slide. Yes, and it's if you're a Sami woman in Sweden and you have any kind of alcohol problem, we don't have anything for the Sami women that you can go to a shelter or somewhere. You have to go to your ordinary doctor. And I would say it's very shameful to be a Sami woman having alcohol addiction problem. You have to solve it yourself, or you have to just hide it, and that's very sad, is it? And as you can see, if you are a Sami woman who have alcohol problems, addiction, you got a very low social status in the Sami community, and it's nothing you talk about in common and openly. It's something that you hide, and there is no preventive actions against alcohol abuse within the Sami women. There's nothing. In Norway, you can go to Norway to get help, but that's at the Sanks. It's a long distance to go, and there is a network of national Sami health that exists in Sweden. So you can contact them, and they have a written assignment that if you have any problems, you can go to this Sanks, this Sami health center in Norway. But it isn't everyone who wants to go there by different reasons. Next picture. So I think, as I've heard earlier speaker today, I think we have to build a network between our indigenous societies and start to talk about these issues. How can we prevent alcohol abuse? What can we do about it? What can I do about it? And what can you do about it? And how can we prevent it so the young indigenous women don't get alcoholic? What can we do about it? And that's very good in this conference that we raise these questions. And we also need more research about these topics. Next slide, please. And there is a Sami woman, Mrs. Lena Kroik. She took her dissertation to 2021, and she wrote about a question about what the elder people thought about the death issues. But I think it's her method was so interesting, so that's why I want to mention it. She took this group of elderly people, Sami people, and they walked in the nature. They went to 2 different places, and one place they went with a helicopter because it was so far away from the road, and then they walked along around this area in the mountains and talked and talked and talked, and they had a talk side by side, did they? And they as you see in the slide, they made a fireplace and they boiled coffee, and they have this kind of deep talk. And I think that's what indigenous people do. They often make a fireplace, a fire out in the nature and talk. And I think that's a good way of talking, to sit around the fire and look at the fire and talk about this heavy things about alcohol abuse. What can you do? What memories do you have? And so I think that's a method I want to mention, and I want to start this discussion. How is it something we can work with even more? Just this deep talk and this fireplace and this way of talking and walking and doing something at the same time. And that's something Sami women does. They prepare the food and and they start to talk about deep things. Next slide, please. And this is a picture I chose to symbolize this knowledge. This is old Sami woman. Her name is Elsa Laula, and she's given the knowledge and her wisdom, give it further to this young Sami woman. And this is a poster that's hang outside Umeå University. And the sign up there, it's Dalve, winter. It symbolizes it's a project that where we show the Sami artists at Umeå University outside the wall. So that's something. How can the elderly women's knowledge be accepted, and how can we pass it to the next generation? Next slide. Yes, and this is my mom. She passed away many years ago, but she's fishing for the household, and she didn't use alcohol. She was not grown up with that. And I want to, she wasn't grown up with that. And it was the colonization in the Sami land and also many other indigenous societies, communities who, when the colonization came, the alcohol also came with the colonization, with those people who colonized the indigenous people. And that's also another thing I want to discuss during this conference. How is the colonization, what role does it have among this in this alcohol abuse discussion? I think I will stop there, and we can have a discussion or a talk about these issues. So I will say Gito. Thank you.
Thank you. Perhaps we could move on to our next presenter and discussion, Christine Petawabano. Does she have the mic there? Does she have audio, Christine? Are you able to unmute yourself, Christine?
Hello, good morning.
Hi, good morning. So nice to see you. Perhaps you could move on to do your presentation, and then afterwards we will open up to the group for Q&A and anything Dr. Poole has to add as well, and we could have a group discussion rather than pose them individually.
Okay, what's my time frame? Because I can go from 10 minutes to an hour.
My timekeeper here beside me. So we have until 11:50. Well, 11:50 we'll start the Q&A. So we need to be wrapped up with the presentations by 10 to 12.
Okay.
So maybe you could speak for 20 minutes or so, or half hour, and then Dr. Poole can add hers, and then we can have a group discussion.
All right.
I'll leave that to you, Christine.
Okay. Put on my timer. What you Mstin naskumun na bezwidum de good ha. Mstin have no goats and gason EU inu skoni. Good morning, everyone. My name is my spirit name is she that comes with the morning light, and my legal name is Christine, and I am EU Inu from the James Bay region of northern Quebec. First of all, I was disappointed that I wasn't able to join you guys there in person. And I just want to thank you too as well for making arrangements for me to present, to still take part in this conference, in this symposium. I'm in Montreal, so I flew here from northern Quebec down to Montreal, and I was supposed to have my connecting flight yesterday evening, but that didn't work out. So, but you know, I'm here, and so I want to start by telling you you know who I am, and I got involved with the you know with the work here that I do through my own personal experience. I've in my education, I went through a different avenue, and with my work too as well. I work in communications, so but with being an advocate in my community, it's something that I do on a side, so it takes up a lot of my time, and I wouldn't be a successful person today without having the compassion of my people, of what we what we went through, and also to heal myself and to continue being on this path, on this red road. So a bit of history of where I'm from. Like I said, I'm from the James Bay region, northern Quebec, and I am a third generation residential school. The first generation would be my grandparents, who were impacted by residential school, and my parents, who I am grateful that they're still with me. They're the residential school survivors, and then I'm their generation, so the intergenerational that has happened there, and so I can say that with what the social issues that what we go through today in my community, in my territory, stems from the residential school. And just to give you a kind of a picture of what residential school is and was, my parents, I'll share the story of my father. And they were in the community of Mistissini, and it was a place of trading. They trade their furs, whatever my grandfather had killed in the winter months, and or fish that they caught. That was the time that they would bring it to the community of Mistissini, and it was a trading post back then. They brought their stuff to trade, to get more supplies, so that they can go back up to their hunting territory. And this was the time where the residential schools, the Indian agent came to the communities, and my father was 5 years old at that time, and so he knew nobody else but his family, and also the other Iuds that were in the community coming in to trade too as well. So a big yellow plane was by the water in Mistissini. The Indian agent came to my grandfather and said, "Do you have any children?" So my grandfather says, "Yes, I do have children." So the Indian agent said, "We're going to take them and they're going to be going to school. You have no choice but to let them go." So my grandfather picked up my dad and put him on his shoulders and said, "You're going to go away and they're going to teach you. They're going to teach you another language to speak." So my father was 5 years old. He was crying. He didn't want to go. He was playing with his friends. They were playing with little pebbles and throwing them in the water, see who has the most skips. So my father was put on a plane, and there was different schools there that they were taking. So St. Mary, Ontario, and Moose Factory, Ontario. So that's where they took my father. 10 months, he didn't see his family. He didn't see his parents, his mom. And he didn't know any other language. He had to learn another language. So 10 months out of the year, so that's where he was. And the same thing for my mom. My mom was a little older, she was 7. My dad was in this residential school until he was in his early teens. And my mom was in the residential school in her later teens. I think she was 17 when she left the residential school. So pretty much they grew up in the residential school. So this was a huge impact on the development of both my parents. And mind you, it wasn't just them, that it was other children from all over. And my parents met when they were in their early 20s, and started having children. So that's where I came. I'm the fourth of 9 children, and one has passed on to the spirit world. So with this impact, it created a lot of issues, social issues. That's where family ties were broken. Imagine, like trying to raise a child when you don't know, how do you raise children, and having to deal with the memories of what has happened in our residential schools. I don't think I need to mention those. I think we know what was going on in these residential schools, all the abuse that had happened, and trying to, like they say, erase who we are as people. And but today, I'm here, I'm strong, I'm alive, I'm resilient. I've connected back to what was trying to be destroyed, what was trying to be taken away. I'm here, my people are still here. However, it is a great challenge to overcome the struggles that we have faced and that we are still facing today. But we found the key, I guess, is reconnecting back to our ways, to our culture, to our language. I'm very fluent in my language in that is my first language. And I had to familiarize myself with it because I left to go down south to pursue an education. So I left at 14, and but I was connected with my family. However, my language started to change. In my mind, my first language started to become English. But when I moved back to the community and working in communications, and first and foremost, we put our language first, and that's what we do. Our radio, our everything there that we do it in our language. So it really strengthened me to reconnect back. And as mentioned before, in my introduction, I just celebrated my 13 years of sobriety. And it was my second time around. And in my early 20s, early mid 20s, I was a user, a heavy user with alcohol. And so I grew up, drinking all the time. But I stopped for a while. I stopped for a few years. And but I went back to my old ways and was drinking constantly for about 3 years. And back in 2008, 2009, so that's when things started changing again, and became sober. And being on the sober path, I said that my sobriety will always be first and foremost in my life. And even before my family, before anything. Because if I don't keep my sobriety first and foremost, I will lose those things again. My job too as well, my home, whatever there that I have, my self-respect, I will start losing them again. And I didn't want to do that. So I said, okay, from now until I pass on to the spirit world, this will be my most important thing. And it has led me on a path of discovery of who I am as an Indigenous person, a woman. And being on the red road, picking up our ceremonies that I hold very dear to me. And I just finished my Sundance this summer, my 4 years, and it's a very good accomplishment. And the people that I've met, that I've connected with, are from the same path. They've encountered similar challenges in their lives. And just standing with them, it's making us stronger. And more are standing up with us. More and more are returning to this path. The decolonization is where, we need to work on. Sometimes, like today, it's not the Western society, it's not the Westerners that we're going up against now. It's amongst ourselves. It's because we were taught, my parents were taught that being Indigenous is wrong. So they passed that down to us. Ceremonies are bad, ceremonies are evil. That is what my parents were taught. And that is what they wanted to teach me. I grew up in a Baptist home. My parents are Baptist and what they call, born again Christian. So I grew up with that. Sunday school, summer camp, going to Christian camps. That's where I grew up. But there was always this voice within me, my spirit longing for, to embrace and to bring alive of what makes me an Indigenous woman. And later on in life, I returned to that. I went into a sweat lodge and it felt like home. And from there, that's where I find my strength. That is where I find my healing. That is what keeps me grounded. Going to sweats, going to different types of ceremonies, the shake tent ceremony, the tie-ups, celebrating rites of passage. Rites of passage is celebrating who we are as people. You know, rites of passage starts from the birth of a child, right up until, you know, the day that you pass on to the spirit world. There's different teachings, there's different ceremonies. And the more we practice those ceremonies, the more we detach from what was wanted to be taken from us. They wanted us to be Westerners. But the Creator didn't want me to be a Westerner. The Creator wanted me to be a Iusko, a Inusko. That is what we struggle today in our communities, in our families. Just like me, our people are still fighting alcoholism, addictions, different types of addictions, drug addiction, you know, youth protection, having children, having to place children in homes. They have to be taken away from their parents, especially our young families. That's what they go through. And I sit on the Cree Health Board. I'm the community representative for my community. And I'm also the vice chair for the Cree Health Board. And I've been the representative for 6 years. I've been re-elected. And I'm grateful for that because I'm an advocate and I speak on behalf of my community and the Cree Nation as the vice chair. I sit with other members. Each community, there's 9 of us. There's 9 Cree communities in the James Bay region. So we have one community representative and they speak on behalf of their community. So that's where I sit. And now, you know, we're trying to change things. And we want to make this healthcare system ours, adapted to our ways. And incorporating our medicines. We want to give our people the best of both worlds, the Western and also who we are. Bringing in our medicines in there to tell, you know, to make that offer to our people and say, these are the medicines that are available to you. You can take the Western or you can take the, you know, traditional medicine. It's up to you. That's taking ownership of our healthcare system by making that available for, you know, for our people. And the youth protection too as well. You know, taking children, it's like going back to residential school, you know, taking the children away from their parents. We're changing that system too as well. We're in the process of it. And we want to make the youth protection adapted to us, how it's best served for our people, for our children, our families. That is what's in process right now. It's kind of like we're fighting with the provincial government on that, but we are fighting it. It's not them that are going to control it. We're going to control it because it's our children, our families. that's the way we want to go about it. And what we encounter, like I said, it's to take ownership, to take what was ours and seeing it, and for our people to see it, and to learn from one another. For many times we're just going around in circles. It's like a vicious circle. And our families, like our people, a lot of our people didn't understand that. Didn't understand that the connection of our past, the traumas that we went through, is related to who we are today, you know, what's happening today. It's so many of them think that it's alcoholism is the root of all evil, you know. They don't, a lot of them don't understand that it's a coping mechanism, that there is an underlying issue of why they're abusing the alcohol, why they're abusing the drugs, why they're neglecting their, you know, their children, their families, the abuse that happens too as well, you know, amongst each other, with our elders too as well. But there are many of us who see it, and there are many of us who are advocates for this. And when I picked up my tools that the Creator has instilled in me when I was born, I used them. I helped my people. And one of the key things that we found is land-based, returning to our culture. A lot of our people, our young people, you know, we take them out on the land, and they say that they don't know how to survive. You know, a lot of them haven't been out on a canoe, you know, the paddling or the snowshoeing, the hunting there that they did, the rabbit snaring, the killing of big game, or you know, geese, the different migrations. So a lot of them have started learning now. But that's good, you know, it's good that it doesn't matter what age that you go back to. The important thing is that they're willing and that they are learning from it. Back in the year 2000, I took part in the first healing journey, and it was walking 550 kilometers on snowshoes. The plane dropped us off at this old trading post way up north, and we had to walk on snowshoes back to the community, back to my community. We didn't have to have doctors or psychologists there. Our doctors and psychologists, psychiatrists were the trees, were the snow, and the fire. My people that I was walking with, those were my medicines. And that's why it was called the healing journey. I did a lot of reflection and a lot of healing out there. And then this summer was our canoe brigade. We took out some youth, took them out on canoes, and it was a 6 days out on the land, and just helping them, guiding them, supporting them to reconnect. So we are on the right path. This is what we do. And this is my passion, where, you know, where it lies. And this is what I want to teach my people. And this is what the Creator has given me. And this is what I want to give back. That is what I wanted to share. I don't like I said, I don't have any formal Western education. I learned from my healing, and that is what I continue, and that is what I want to continue doing for my people and for whoever wants to hear my story. You know, I'm very blessed and I'm very honored to be part of this this seminar. And if you have any questions later on for me, I am more than happy to answer with what I can. Thank
Thank you,
you.
Lisa. Thank you. Perfect. Thank you, Lisa. Dr. Poole is going to build onto both of your presentations here, and then we'll open up to questions.
So amazing what both of you have spoken about this morning, and really offers us a lot of wisdom to think about our work in connecting to your work and building in that idea that you mentioned of two-eyed seeing, of holding the best of Western and the best of Indigenous cultures together and thinking about where to go from here. I've had the privilege of meeting lots of Sami people at the circumpolar health conferences in the northern parts of our countries. And I've also had the great privilege of walking with an Innu community in Labrador from the Sheshatshiu Nation. Around developing their ideas about what it is to prevent fetal alcohol spectrum disorder from a community-led, community-driven, culture-driven approach. So both of the things that both of you said were really touched on the thinking. I just wanted to mention that for me, it really means that those of us who are not Indigenous really take up this work in understanding what it is to do reconciliation in this context. And I just want to use the example of the Truth and Reconciliation Commission's call to action number 33, which is we call upon the federal, provincial, and territorial governments to recognize as a high priority the need to address and prevent fetal alcohol spectrum disorder and to develop, in collaboration with Aboriginal people, FASD preventative programs that can be delivered in a culturally appropriate manner. And it seems to me that this is our work of walking with Indigenous communities, sharing what we know and supporting this work that has been so eloquently described. In our work on trying to do this, we've walked with the Thunderbird Partnership Foundation, an Indigenous group in Canada, a national Indigenous group in Canada, leading work around Indigenous health and wellness and substance use concerns. And they have really helped us think through things like developing an Indigenous approach to FASD prevention. And I just wanted to say one quick thing about what we've been able to talk about together, because it really draws on what has been presented here and links to the material I talked about earlier. When we came together with Indigenous representatives from organizations and communities to talk together about what it is for us to work on this reconciliation call to action. Here's what the 8 things we felt we needed to do. We needed to center prevention around Indigenous knowledge and wellness. We needed to use, which is the theme of our conference, a social and structural determinants of health approach. We needed to highlight relationships, correcting the breakdown of family and community relations, which has been so well described. We needed to honor that this work needs to be community-based and driven. We need to think about that idea in FAS prevention of the wraparound support and holistic services that we talked about before. And just as well presented, we need to think about a life course approach, not just the moment that you're pregnant, but how, all the seasons of wellness that we can support with positive parenting relationships and other ways. And we need to really think about what does resiliency look like and support women, families, and communities on that. And interestingly enough, and maybe this is partly because I was involved, was that we talked about how we ensure the long-term sustainable funding and research on this, that we don't just provide short-term funding for these approaches, but we recognize the importance of long-term gender responsive and culturally driven budgeting by our healthcare and social care systems. So I just wanted to mention that for me, this is the work that we do in partnership with these wonderful women. So thank you.
Thank you so much, Dr. Poole. I'd like to invite folks from the floor to pose any questions or comments that you may have to either one of our three presenters or all. We'll begin with the floor, and if there's no questions from the floor, we'll move to the Zoom to our Zoom attendees. My goodness, it's a quiet, shy group. This is so unusual. Okay. No questions from the floor. Do we have any? Oh, sorry. Oh, we do have one. Yeah, please go to the mic. Thank you. Thanks.
Hello, can you hear me?
Perfect.
I think it's more of a comment that it's really great to be here today to see what's happening with regards to barrier-free service. I know in Ontario, we've just got a huge amount of money that's come from mental health and addiction services for the next 10 years, which is great. I worked in domestic violence and sexual assault before I came to work at Portage, and also with at-risk street youth and those that were living with concurrent disorders. What we found was that, again, mentioning the silos, this is kind of from before, but also here, is that you're now seeing that word community is used more often, and it means that we are actually connecting. And I think this is the way that we can help each other, but we can also learn from one another. So often when people aren't learning and they're not sharing, we don't give the service that we need to. And as I said to you last night with the spider rep, the reason why is that if you create it so that there's stuff for everybody and what their personal need is, because it has to be client-centered, because that is a strength-based approach, which ultimately can determine your own future. And I just think it's really great that we are at a place where community seems to be the key word, connection, and also that we're getting rid of the silos. So I think that's just a comment, and yeah, that's it. Thank you.
Thank you.
I have a comment. Sorry.
Please go ahead.
Oh,
There's Rebecca. Like, where's?
I just want to say that I noticed in all three presentations and in Dr. Poole's presentation before, there was reference to walking, being out on the land and walking. And Christine, with that wonderful mention of the doctors and psychiatrists being the snow and the trees. And I just want to say it's very empowering to hear that a recovery or a treatment plan doesn't have to be fancy. And it doesn't have to occur in a clinical setting. And I've always been a big believer of that. You know, sometimes it can be very, very simple, and it's really awesome to hear our panelists drive that home. Thank you.
It's so interesting when I've been working with the folks, the Innu folks in Labrador. They also, like you, have built in long walks with women on the land as a key way of learning and connecting to culture and growing and changing. And I think it's such an important thing for us to recognize that that a lot of us in Canada need to learn a great deal about Indigenous cultures and ways of hailing and connecting to cultures like the Innu culture that was nomadic and did spend a great deal of time with the reindeer and the caribou, as well as in community together. And it is humbling and important for us to listen about the wisdom of those ways and to learn from them. So really appreciated hearing more about it.
I see that Christine and Ella Karine have their hands up. So I think, do you want to add to that, Christine and Ella Karine? Oh, Ella Karine, you're on mute.
Who will start? Christine?
Okay, thank you for the comments. I just wanted to add that you know, our people have, you know, battling with addictions and making that decision to, you know, get the help that a person needs, you know, whether, you know, it's a man or a woman. We use our the treatment centers that are down south, and but most of them are Indigenous, like the one in New Brunswick, and also here in Montreal in Oka. But now it's the Cree Health Board is in the process of building our own treatment center in our territory, something again, you know, which is going to be ours. And one of my the facilitator that I was working with is doing community tours, going to each community and saying, what would you like to see? Especially the ones that have gone down south to a treatment center, they feel disconnected. They feel disconnected to it. And so they give their input in, this is what I would like to see. This is what I saw. This is what didn't work for me. This is what worked for me. So next year, within maybe 15 months, we will, you know, we will build our treatment center in one of the outside of the Cree communities, and also we know the importance of the aftercare, you know, like and also we see that it has to be, the strength of it and the foundation of it needs to be land-based. That's key, you know, reconnecting back to the to our ways, you know, to the teachings, to how we lived and what we ate, you know, how we spoke. So it's nurturing that is what will help a person grow, you know, like our EU, you know. So that's what I wanted to add. Thank you.
Thank you. Ella Karine?
Yes, thank you. About the residential school, I want to show you a book. I wonder if that I was the co-editor. When I was 8 years old, I left my home and I haven't come back yet. And this is school memories from the residential school. So I agree what you say, Christine, and I'm also myself been living in a residential school for 8 years. So it's that's also an issue to talk about, but not in this conference. Thank you.
So there is a question that came in on virtual, so we'll do that one, and then we'll hand this question over back to the person in the room, if that's okay. So we have a question. As an FASD program coordinator in Ontario who is non-Indigenous, what would be my first steps in approaching this topic to show I am not judging and wish to walk with them on this journey to provide culturally relevant programming? I have been facing barriers such as having no participants for FASD related workshops. So that is the question.
Would anybody like to answer that? Dr. Poole?
I can
Looking to
start,
speak
but
on that?
Yeah, you know, the stigma around alcohol use in pregnancy has been such a huge one. I mean, stigma around women using alcohol is one, but it just raises another level when you're using alcohol in pregnancy, and then another level if you're an Indigenous woman using alcohol in pregnancy, right? So it is huge, that barrier to overcome. And it's just really nice to hear that that's a concern, and trying to think about how you might do that. And, you know, there may be so many ways of doing that in Ontario. I know there's a number of FASD community-based folks funded by the Ontario government that are working in Indigenous communities. And I guess my first advice would be to connect to them about what they think is a good way to connect, because they may know the best. The other way in, I think, is spending time with friendship centers or other Indigenous organizations and building relationship, and even going and spending time in those organizations so that people there get to meet you and to know that you're receptive and non-judgmental. And I think that reaching out to stand in those community-based centers with others is a really important signal that we are doing 75% of the walk, rather than expecting that Indigenous folks do the 75%, and we sit there in our organizations and just accept people. So that's my my first quick advice, and maybe Christine has other things to add, working in with the Cree and Innu in Northern Quebec.
Yes, thank you very much. I totally agree with you on that. It's sometimes we you know, like in my community, we have these, you know, doctors coming in. It's the mentality sometimes, you know, like, oh, I'm here to fix the Indian, you know, and we don't need to be fixed. we need resources. We need help, yes, but we need to work together. Get to know me, what I went through, in order for you to, you know, to provide those the help that I need. You know, I think it can be, it's applied in, you know, in so many areas. It can be applied to so many areas, and one of them is the FASD. It's like we need to understand. We need to know the story of the person. The more you know, the more that you'll be able to provide, you know, what they need. So that's my my response. Thank you.
So now we have a question from the room. If you want to ask your question, tu veux poser ta question?
Well, it's maybe a little bit more of a comment than a question, and maybe in line with the last questions. I guess the last question, what I would propose is patience. Nothing happens fast. when you try to cross-culturally support, learn to know and help each other. So yeah, sometimes you go there at night, nobody shows up, still go the next night. They will.
That's a great point.
Thank you.
I want to thank you, Christine and Ella Karin and Dr. Poole. I heard a lot of good things today, mainly words that are really tracks for people who are trying to work with Indigenous communities. Listening is the key word. Ownership is the key word. And relating this to the theme of the conference, when we talk about women in addiction, we need to look at it not just as women suffering from addiction. They are also the initial vector of change in their communities. I'm sorry, there's just a lot of memories that are coming back in my mind. But in the communities that I have seen who succeeded, walking together as a community towards healing, most of the time it came from the woman who, in the name of the future generations and of their children, initiated the process. So they are not just in need, they are part of the answers. That was my comment.
Oh,
Thank you.
Wow. Thank you.
So I have received another question on the Zoom that I'll read from Melanie. So her question is, it was mentioned by Elder Karine that alcohol was introduced by colonialism. I'm wondering, was there something before, or was addiction as we know it not existent pre-colonialism? And she goes on to add, her main curiosity is if this was something that Indigenous people had any prior knowledge on how to cope with, and if this is something that can be explored and revisited.
Who shall answer that question?
Anyone can answer of the three panelists, but I mean, especially Krista and Ella Karine as having been from the communities impacted by colonialism, of course. If you have knowledge of that.
I can just leave a short comment. Among the Sami people, we didn't have any kind of drugs before the colonialism. It was very, very rare. I haven't heard about it. So that's, I mean, that was the alcohol. It was something that the colonialism brought into the indigenous culture.
Thank you. Christine?
hi, yeah, thank you. Well, I think prior to that, yeah, there was, I do recall, you know, like from stories from my parents and my grandparents that alcohol was there, and it was called homebrew, but it was used to, you know, like for celebration, you know, like New Year's and things like that. You know, of course, you know, we celebrated that, but the majority of the time, our people were not in communities. They were out on the land. You know, there were 2-3 families 10 months out of a year, it was only in the summertime that they would go back into the communities like Mistini, where I'm from. And a lot of it had to do with just, trading and weddings. So, like you have to have, yeah, most of the time, we incorporate alcohol when it comes to celebrations. So that's where it came from. But for it to be abused, no, I think it was after residential school. That's where, it's alcohol was a coping, we had to cope, families had to cope, our grandparents had to cope. Their children were taken away without being consulted or anything. It's just like, we're taking your kids away, otherwise you will not be you won't be getting your supplies to go back to your hunting territory, or it's they didn't have a choice. So, it's already there. It's the control was there, had already existed there. So that's my response. Hopefully I've given you some insight on that. Thank you.
Yes, thank you.
Something to that.
We just have one more comment here from Dr. Poole wanted to.
I just think it's really important that we recognize that every race and every culture, people use substances, and we really have to not put a lens on Indigenous substance use as the biggest issue, but the as you so well described, the conditions that led to substance use problems and the fundamental concerns that underlie people's substance use. That's how we help people move forward. And while we need to be aware of substances and their, as I mentioned earlier, their, the effects that matter for women in terms of women's bodies versus men's bodies, and how alcohol and other substances are processed and metabolized. Really, the focus is not the substance, it's the people, and listening to what they see as foundational to the problem.
Thank you.
Thank you.
Excellent point.
We have another question from a person in the room.
I'm the person in the room. One of the things said by both Erica, Karen, and Christine that really impacted and actually hurt hearing is the word shame, and the fact that shame was the underlying action of society to people who developed a problem. And it's probably the most antagonistic attitude in an attempt to try to help someone. It will drive people away rather than drawing them near. And something else that Dr. Poole has been emphasizing, and that resonates, is this notion of gender responsive, culturally driven budgeting.
Yeah.
And shame and shaming usually comes from a societal attitude, which drives public policy. It's picked up by our politicians and it's reflected in public policy. It doesn't exist in a vacuum. So how do we move beyond just treating people who have been hurt and changing social attitudes so that the notion of shaming not only disappears, because those who are fortunate enough to get help and will overcome, but that society itself changes. So shaming doesn't become a norm. And I know a little bit about Sweden, and Karen probably confirmed this, that shaming of women and women with problems, be it mental health problems or substance problems. It's not restricted just to Indigenous people. It's restricted to women. It's a gender-driven thing. And it has to do with gender. So how do we, Dr. Poole, what's your advice or anyone else? How do we move from the treatment center level of trying to rectify the wrong to the society level, to the community, to the political level? So the gender responsive, culturally driven budgeting, be it declared by the UN or us or anyone else, becomes feasible in a reality.
Well, I think we've heard a great example of it this morning by hearing of your story of being in recovery and not necessarily making it the first time, but continuing on the path and showing leadership in the community. And to me, this is the way it changes, is when people have the courage, such as we've seen here, to name their story, show their resilience and strength to us, and give us some guidance about how to go forth. So for me, it's all about hearing these stories and really creating the conditions for the stories to be told in contexts like this, and to really listen to them and have it infiltrate all our work. Somebody mentioned to me at the coffee break about, that idea of you tell two people and they tell two people, and that whole way of spreading wisdom. And I feel like the two people who've talked about their stories this morning really inspires me to think about how can I continue to put this into the work I do and to and the people around me as well. And so to me, the answer is that of your great question around shame has just been modeled right in front of us so well. So thank you for that.
Thank you. That was a great question. I don't have any other questions from the virtual. But there is someone named Joanne who made a comment, and I believe it's in response to the various mentions of walking this morning. And it was a comment that reads, "It can be so much easier for folks to talk side by side than face to face all the time."
Yep.
So there's probably a little bit of additional insight there into I'll just call it the magical power of walking. Do we have a final question from the room?
And walking in nature, I think, is an added benefit, not just walking on
Nature
city
is
streets.
medicine.
Yeah.
Yeah.
Yes.
Okay, so if I'm comfortable saying that we are done with the Q&A, Tammy?
Thank you so much to all of our speakers. I'm very sad that I didn't have the opportunity to shake both of your hands and meet you in person, maybe one day. But thank you so much for your efforts in joining us today and sharing all of your learnings and your wisdom with us. Thank you. And thank you, Dr. Poole,
Thank you
for jumping in. Yes, thank you.
Yes, big applause. Hopefully, Christine and Ella Karine, you can hear the big applause. And thank you so much.
Enjoy the rest of your day.
Yes. And for those of us who are here present in the room, so now it's lunchtime. So the way lunch is going to go, if you know on your schedules, there's a buffet service that starts right now. And then I'm going to speak a little bit in French because I'm here, I'm supposed to be bilingual. À 12h20, nous aurons des participants qui vont monter sur la scène pour faire une présentation. Gino Mallet, Bernard Gauguin et Marie-France Clavette. Ça fait, je vais les introduire à 12h20. Ça fait, je vous invite de prendre une assiette présentement. et de prendre le dîner. Et on va commencer dans 20 minutes avec la prochaine présentation. So next presentation starts in 20 minutes. Please go grab a plate of food. And then in about 20 minutes, I will introduce Gino and Bernie and Marie-France.
Excuse me, I
Oh.
just, Rebecca, forgive me
Yes.
if you mentioned this and I missed it, but if the folks would just please allow our presenters to go to the table first to serve themselves some lunch and give them the opportunity to have a bite, please, before they take the stage for their presentations, it would be much appreciated.
Yeah, so Gino and Bernie and Marie-France, go, get up there before the masses do and take all the food. Thank you. On se reparle dans 20.
Thank you so much.
Stop moving. Figure it out. Figure it out. You can do it. Love, keep on running. You gotta get through today. Yeah, my love, keep on running. Gotta keep those tears at bay. Oh, my love, don't stop running. Gotta send them up in flames. Don't stop, tomorrow's another day. Don't stop, tomorrow you feel nothing. Just keep moving. Don't stop, the past will trip you up. You know right now how to be enough. Just keep moving. Figure it out, but don't stop moving. Go, go, go. Figure it out. You can do this. So my love, keep on running. We gotta get through today. Yeah, my love, keep on running. Gotta keep those tears at bay. Oh, my love, don't stop running. Gotta send them up in flames. In flames. In flames. In flames. Go, 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 figure it out, but don't stop moving. Go, 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 figure it out, you can do this. So my love, keep on running. We gotta get through today. Yeah, my love, keep on running. Gotta keep those tears at bay. Oh, my love, don't stop running. Gotta send them up in flames. In flames.
We're gonna ride till we fall. They say we got no future at all. They wanna keep us out, can't hold us down anymore. We're gonna ride till we fall. When we hit the bottom, nothing gonna stop us. Climb to the top and you we could be the greatest ones who never made it. Yeah, I could be talking to you. They tryna hate, but we won't change anything at all. Oh, we gonna ride till we fall. They think we just dropped out, living at our mom's house. Parents must be so proud, they know it all. No, they don't speak our language, they say we're too savage. keeping on going till we can't go no more. We're gonna rise till we fall. Yeah, when we hit the bottom, nothing gonna stop us. Climb to the top, and you know we could be the greatest ones who ever made it. Yeah, I could be talking to you. They tryna hate, but we won't change anything at all. We gonna rise till we fall. They think we just dropped out, living at our mom's house. Parents must be so proud, they know it all. No, they don't speak our language. They say we're too savage. Yeah, no, we don't give up anymore. We gonna rise till we fall. Gonna rise till we fall. They don't speak our language. They say we're too savage. Yeah, no, we don't give up anymore. We gonna rise. We gonna rise.
You're a world away, somewhere in the crowd, in a foreign place. Are you happy now? There's nothing left to say, so I shut my mouth. So won't you tell me, babe, are you happy now? You're the only one who can up and run, leave me just as empty as the day you came. You hold all the cards, all the broken hearts strung over your shoulder till it's all in vain. And only you know the strength in your teeth, the washing the weight of your pockets so deep. And only you're a world away, somewhere in the crowd, in a foreign place. Are you happy now? There's nothing left to say, so I shut my mouth. So won't you tell me, babe, are you happy now? Are you happy now? In the palm of your hands, you can make me dance, spin me round in circles till I'm wrapped in string. You keep on talking sweet till your fingers bleed, but don't you dare ask me how I've been. Now only you know the strength in your teeth, the washing the weight of your pockets so deep. Lonely, you're a world away, somewhere in the crowd, in a foreign place. Are you happy now? There's nothing left to say, so I shut my mouth. So won't you tell me, babe, are you happy now? Are you happy now? Somewhere in the crowd, in a foreign place. Are you happy now? There's nothing left to say, so I shut my mouth. So won't you tell me, babe, are you happy now?
about my transgression. Still in my heart somewhere, there's melody and harmony for you and me tonight. I hear them call my name. Everybody says, say something, say something, say something, say something, say something, say something. I don't wanna get caught up in the rhythm of it, but I can't help myself. No, I can't help myself. No, no. Caught up in the middle of it. No, I can't help myself. No, I can't help myself. No, no, no. Caught up in the rhythm of it. Maybe I'm looking for something I can't have. Something I can't have. Maybe I'm looking for something I can't have. For something I can't. Maybe I'm looking for something I can't have. Something I can't have. Maybe I'm looking for something I can't have. Something I can't have. Sometimes the greatest way to say something is to say nothing at all. Sometimes the greatest way to say something is to say nothing at all. Sometimes the greatest way to say something is to say nothing, but I can't help myself. No, I can't help myself. No, no. Caught up in the middle of it. No, I can't help myself. No, I can't help myself. No, no, no. Caught up in the rhythm of it. Maybe I'm looking for something I can't have. Something I can't have. Maybe I'm looking for something I can't have. Something I can't. Maybe I'm looking for something I can't have. Something I can't have. Maybe I'm looking for something I can't have. Looking for something I can't have. Sometimes the greatest way to say something is to say nothing at all. Sometimes the greatest way to say something is to say nothing at all. Sometimes the greatest way to say something is to say nothing. Oh yeah, we can do better. I know it hurt bad, your mom left you dead when you were a little girl. You think I'm gonna leave cause history repeats, we've seen it around the world. Well, all that we're told is this, so get old, we'll cheat, and we'll both get hurt. Against all the odds, we'll pray to the gods that this love works. When all we see is bad blood and mistakes, all we hear is sad songs about heartbreaks, and no matter how long it takes, we're not gonna give up. We can do better. We can do better. And nothing lasts forever. We can do better. Things can get rough, we might drink too much and say things we shouldn't say. Forgive and forget before we go to bed, and we're gonna be okay. Some people pretend it's not gonna end and then up and walk away. But that isn't me, I'm not gonna leave, I'm here to stay. When all we see is bad blood and mistakes, all we hear is sad songs about heartbreaks, and no matter how long it takes, we're not gonna give up. We can do better. We can do better. And nothing lasts forever. We can do better. I'm not worried cause the thing is, we can do better. I know when all we see is bad blood and mistakes. All we hear is sad songs but heartbreaks, and no matter how long it takes, we're not gonna give up. We can do better. Oh, we can do better. And nothing lasts forever. We can do better. We can do better. On to someone new. Hope life is beautiful. You were the light for me to find my truth. I just wanna say thank you. Leaving to find my soul. Told her I had to go. And I know it ain't pretty when our hearts get broke. Too young to feel this old. Watching us both turn cold. Oh, I know it ain't pretty when two hearts get broke. Yeah, I know it ain't pretty when two hearts get broke.
Okay, so the next presentation is going to start in 4 minutes. Ça fait Bernard, Bernie et Gino et Marie-France. Si vous êtes là, je vais vous inviter peut-être à venir sur la scène dans les prochaines... Vous avez comme 2-3 minutes, là, ça fait. Venez vous installer quand vous êtes prêts. Est-ce que vous avez une présentation aussi qui va jouer sur mes écrans? Oui. Oui? Oui. Okay, so AV team, they also have a presentation. You're all set? Okay, so before this next showcase starts, I do want to mention a very small modification. Well, it's not small, but it's, you know, it's important. Modification to your program. So in the programs that you've received, it says that the boarding of the bus and the departure takes place at 2 o'clock, but that's actually been changed. It's a little earlier now. So this showcase is going to go until 1:30, and including Q&A, there'll be a bit of time, but at 1:30, I will invite everyone to go out to, the buses will be waiting outside as of 1:30, so that departure can happen at 1:45. Okay, so it's a bit earlier than mentioned in your program for those of you going to Cassidy Lake. Okay. Bon, nos prochains invités, our next guests are attends, les noms, je vais m'assurer que j'ai les bons noms. Yes. Gino Malin, Bernie Gauguin, Marie-France Clavette are going to be doing a showcase of, I think it's a program. Yes. Yep. Okay. Merci beaucoup. Thank you.
We just get started?
Yep.
Great. Okay. Thank you very much to the organizing committee for Portage for hosting such a great symposium. It's been an awesome, awesome 2 days, and looking forward to hearing more great speakers. And thank you also very much for inviting us. We're very happy to be here and look forward to sharing the information that we have about one of our programs that we've recently transformed. So what I'm going to talk about in my section is a little bit of the preliminary work that went behind this significant transformation of our services. Talk about some of the principles and guiding ideas that helped us guide our work. I'm going to talk a little bit about the New Brunswick Continuum of Addictions and Mental Health Services continuum and how we want to improve it based on a lot of the ideas that we heard about this morning. I'm also going to talk a little bit about the New Brunswick Addictions and Mental Health landscape to give the audience an idea of what type of services we have. And then I'm going to turn it over to my colleagues, Marie-France and Gino, and they're going to talk in much more detail about the program itself and how they provide services to clients and in women in particular. I think we're ready for the next slide. Or do we have a clicker?
Yeah, maybe if we could have the clicker would be probably more convenient.
On the podium?
Oh, there you go.
Got it. Thank you. Okay, so transforming a substance use and mental health program is a lot of work, as I'm sure you can imagine, and a lot of thinking and research went into it before. So in about 2016, 17, we really started an enhancing addiction services project with the Department of Health in New Brunswick, really wanting to look at building a more robust and effective continuum of care. And that the services were built on evidence-based practices. So we did a lot of research, and we focused reviews of the existing services. So we did sort of lengthy and exhaustive reviews of our withdrawal management facilities, of our live-in treatment services, the community services that we had for addictions and mental health, as well as what we had for addiction medicine as well. We consulted a lot of individuals across the spectrum of care. So we talked with clinicians, managers, directors, people with lived experience, clients who used our services, and various other partners as well. And we, of course, did a good review of the literature in terms of what's best practices. And what we really wanted to do was to implement services across the spectrum that would broaden the continuum of care, kind of modernize addictions and mental health services, and really focus on just improving the health outcomes for New Brunswickers. And that has now continued into our recently released 5-year addictions and mental health action plan that really is an interdepartmental in nature. We were talking this morning about having other government departments working together. And that's, I think, what we're trying to do with the 5-year addictions and mental health action plan in New Brunswick, is having departments work more closely together. So some of the key elements of the action plan include things such as improving access, intervening earlier, focusing on population health, matching the right intensity of service to the individual's needs, and also reducing the harmful effects of drug-related impacts as well. I'm going to see if I can make this work. Yeah, okay. So all services that we reviewed and all the information that we received really told us that we need to really transform the system. And this system needs to be based on principles of effective service delivery. We heard from Dr. Poole this morning and others about some kind of guiding principles. So that was kind of one of the things that we needed to do. We needed to develop some principles that would help guide our transformative work. We needed to build an effective continuum of services as well. We had a lot of services, but they often weren't connected. They were kind of siloed, not really talking to each other. And we really also wanted to focus on continuing the work of integration of addictions and mental health services, because in the past they were kind of separated, but also integration with the rest of community agencies, other government departments, really to start working kind of more collaboratively and more closely together. We wanted to create a culture of continuous learning. We heard quite clearly from clinicians that they wanted more education, more training, more knowledge, so they could be more effective in their work with clients. So that really was an emphasis as well. And we really wanted to create a foundation of evidence-informed services. And of course, improving the quality of life and health for New Brunswickers. So what we did to kind of guide this work, we identified 22 principles of effective service delivery. So we kind of scoured the literature, we talked with people, and we identified 22 guiding principles. And they fall into kind of groupings and categories. So the first one focuses on improving the client experience. We want the clients who come to our service to feel welcome, engaged, supported, all those really important things that we know, those relationship factors that really help improve outcomes. We also wanted to focus on service delivery, making it more effective, more consistent, and more evidence-based. We had some principles that focused on service integration, making a system that is sort of better connected, works more closely together, and is more collaborative in nature. And of course, we wanted to focus on workforce development to make sure that the clinicians who do provide the services have the right tools, the right technology, and the right knowledge to provide services. And of course, in New Brunswick, like many other jurisdictions, we do great work, but we're not always so good at evaluating what we do and promoting it. So we really wanted to focus as well on evaluating the services that we provide, to showcase what we do, and also to use that information to help guide improvements as we move along. So these are how we arrived at those 22 principles of effective service delivery. So there was some expert consensus and guidelines in the literature. We looked at the best practice literature as well, recommendations that were generated from the 3 major service reviews that we conducted. And we also incorporated a lot of ideas, concepts, and common themes we heard from clinicians, managers, directors, and clients as well. And there was a lot of existing practices that the clinicians and the programs engage in, but they were never really kind of formalized in a comprehensive manner. And at that point in time, we had an addiction task force, and that task force kind of guided the work and sort of endorsed these principles as well, saying that they were really helpful in moving the system forward to some of the next levels. These are just examples. We don't have time to go to over 22 principles, but just to give you an idea of kind of what they look like. The first one is the participant is a priority for all programs and services. So this falls into the client experience. I have no doubt that when a clinician and a client are working together, that client is that priority for that clinician. However, like most systems, we had a variety of rules and barriers that really made the system not necessarily client focused. For example, one that comes quickly to mind is for the longest time, our live-in treatment services in New Brunswick, individuals had to be sort of sober for 30 days before we admitted them, which kind of made very little sense. It's a program for high intensity needs, and we ask them to be sober before we'll accept them. So those are that's just an example of how we really needed to tweak our policies and our procedures to make them much more client focused. We wanted clients to feel engaged and welcome no matter what door they came into, kind of that no wrong door idea that's been around for a while now, but that to not give them a 1-800 number and go there or call here, to really engage them when they came to us and kind of help them navigate the system as well. And we really wanted participants to be offered a variety of services along a continuum of care that range from low intensity services all the way up to high intensity live-in treatment services as well. So as I said, we have 22 of these types of principles, and they really largely guided the transformative work. And of course, they do include things such as gender and culturally informed services. And in fact, Nancy, Dr. Poole came to New Brunswick and provided some great information to us and some training when we were just embarking on that transformation as well. So part of that work also led us to our 5-year interdepartmental addictions and mental and action plan. So what we wanted to do here is to, as I mentioned, create that continuum of services that is evidence-based, but is also easy to navigate. 2 of the biggest criticism that our services have received, primarily from clients and from partners, is that it's difficult to access and it's difficult to navigate or understand. So as a cornerstone of the 5-year action plan that we have, we want to implement a step care model of continuum of care. This is based largely on the work by Dr. Peter Cornish, who was in Newfoundland at the time, a step care model where a client can step in or step out of services, or also step in, step up, or step down, depending on his or her needs at the time. So we really want a variety of options and a system that is connected and does not work in silos. So part of this work involves, of course, developing pathways and ways of working together. So this is probably like a 5-year transformation plan that'll be some of the next steps. We haven't fully started this transformation yet. We're just at the beginning stages. We're starting to promote a model like this. And one of the key components of a step care model is the whole idea and the importance of co-designing. So this is just our kind of first draft idea to start the conversation. So we really hope to develop a made in New Brunswick step care model that will involve the kind of more formal systems that's delivered by Horizon and Vitalité, but also community partners such as the wonderful work that Sophia Recovery House does in St. John, and other important partners like CMHA, great agencies who do fabulous work in New Brunswick, so that we can all kind of work more together more collaboratively. So I won't go too much into detail about that, but we really want to emphasize that there will be different intensities, and the live-in concurrent disorder treatment service that we're talking about today, that would be at the highest intensity level. So that would be at that intensity level number 6, so really high intensity. But of course, in the lower intensity as well, we really want to incorporate more easily accessible service. So all those services that are online, like other places, the pandemic has really forced us to really develop an online presence. In New Brunswick, we have Bridge the Gap, which is an online website that is a directory of services, but it also has various online tools and information that a person can go to and kind of work their way through it and hopefully get some of the information that they need and also direct them to services as well. Over the last year, we implemented one-at-a-time therapy across New Brunswick in adult services, and it's now starting in child and youth services. So that's a very good example of a brief service where a person can come in and talk to somebody right away. No lengthy intake process, just come in and they can talk to somebody and get the help that they need. And that can turn into a navigation system. It can turn into a one-at-a-time session, or it can turn into a more detailed assessment to help navigate the person to the treatment service that they need. So really interesting work going on in that aspect to just increase access and provide help immediately to individuals. So I won't spend too much more time on that because I know we're a bit tight for time. In New Brunswick, the Addictions and Mental Health Service, there are four kind of key groupings of partners. There's the Department of Health, which focuses more on kind of planning, funding, and monitoring services. There's Le Réseau de Santé et Vitalité, which is a health authority, and they serve most of the northern part of the province and the Moncton area. And although their services are bilingual, they provide most of their services in French. There's Horizon Health Network, which is most of the southern part of the province and in Moncton as well. And their language of work is English primarily, but all services are bilingual or should be. And there's also a great variety of partner non-governmental agencies and private agencies who kind of all are in the addictions and mental health landscape as well. And Portage is an important player in that frame as well by providing their great services at Cassidy Lake Center as well. We have community addiction and mental health services, and there are offices and satellite offices, and they provide assessment and treatment. We have group and individual services as well, and this includes services for gambling, and we have a continuously evolving addiction medicine service as well, which started to focus on withdrawal management, moved on to opioid agonist replacement therapy, and now we're starting to have clinics for alcohol, and also hoping to implement more home-based withdrawal management services as well. Many of the services are combined with an addiction and mental health service in the same building as part of that integration piece as well. We have 7 withdrawal management facilities, so kind of the detox buildings, and they vary from 6 to 20 beds, and they're open 24 hours a day, 7 days a week, and they're generally staffed by registered nurses, licensed practical nurses. Some of them have social workers as well, and we also have attendance, and a physician goes there as well for a certain amount of hours per week to kind of guide the medical treatment as well. As with most withdrawal management, alcohol is considered one of the more dangerous substances, so they're a priority for admission just in terms of the severity and the complexity that some folks can have with heavy use of alcohol. The stay is generally 2 to 6 days, but the stay can be flexible. Pre-COVID, we were offering that service to about 2,000 distinct individuals who were coming through the withdrawal management facility doors. During COVID, that number dipped to about 1,500, but it's starting to increase again as the COVID protocols start to reduce. In terms of living treatment, we have the Campbellton service that we're going to talk about in great detail in a few seconds. There's 12 beds there, and that's the service that we transformed from a 21-day substance use only to 35 to 90-day concurrent disorder service. We also have Ridgewood Addiction Services in St. John that has 12 beds, and that is just starting to be transformed at these days here. We're looking at doing a very similar process as we did in Campbellton. There is going to be some renovations to some of the buildings there, and they're going to adopt the same type of model. We're hoping to increase some of the beds there to 16 beds. I think we'll be able to make it with a kind of the footprint of the building through the architect work. And we also have Early Recovery Center, which is also in St. John on the same Ridgewood campus. And that is for people who are in the very early stages of recovery, kind of that kind of multi-purpose transitional support service where they can go before treatment or after treatment, or as they're kind of planning their transition back to the community. And as I mentioned, Portage is a key player in the addiction treatment community in New Brunswick, where they provide services to youth at Cassidy Lake, a great partner for the Department of Health and for providing great services to New Brunswick. So I'll stop there and transfer it over to my colleague Marie-France, who's going to talk about the program.
So yeah, so how we got started. So we had to develop basic model and framework. So with that, we implemented an implementation committee, so which involved the Department of Health, family members, clients with lived experience. We had Indigenous as well. So how do we transform our 21-day program into the program we have now? So, and the service really wanted to address addiction and mental health issues concurrent. So we program design, developed referral forms, admission criteria from best practices, based on principles, and we based it on the principles of effective delivery, like Bernie had mentioned in the beginning. We identified core programming as well for our group sessions. So one of it is cognitive behavioral therapy, steps for steps as well, seeking safety for trauma and substance use as well, and looked at trauma, gender, and culturally informed care. We also, because the renovations, so we had renovations done for added resources that were put in the program, and also the space for other like sensory room and things like that, and the hiring of other professionals to help with the needs of the concurrent clients. And really the change management and communication. So we did have a lot of communication, a lot of talk with the team. So we're going from, substance use program 21 day to an open end program concurrent. So we did a lot of communication challenge with our team and management as well to help kind of facilitate that. So the first site was Camelton. So we already had our rehab program, our 12-bed program. So it was a perfect site to start kind of that pilot project in Camelton, and the fact that we had a doctor involved as well. So we added 4 new resources to create a multidisciplinary team. So we added an occupational therapist, a psychiatrist, psychologist, an extra social worker, and a human service counselor to make our multidisciplinary team. So the program varies from 35 to 90 days. So when I call the clients for an admission, I usually say they're here for 5 weeks. Our programming is 5 weeks. After 5 weeks, we evaluate with the client if they want to stay longer, and they can stay up to 90 days. So the program is very individualized to their needs of the client. It's an open-end admission, so once there's a bed available, clients come in, and the service is concurrent enhanced. We offer up to 30 hours of group sessions a week, and also depending individual sessions depending on the level of need of the client. The service is very flexible and individualized. So our old program, the way it was made, it was kind of like the client had to fit the program. Where with this service, it's like we fit the needs of the clients. So the treatment plans that are established with the clients during their treatment is very individualized and goal-oriented based on their needs. Like, for example, if we have a client that comes in and has difficulty with staying in group sessions, well, we might develop a plan regarding that person to maybe join the sessions in the morning, and in the afternoon do another activity. So we really try to individualize our treatment plans when it comes to the clients. We involve families and support as much as we can. The families are always involved in the treatment, especially when it comes to discharge planning as well. So we want the families and the communities involved in the discharge plan for our clients. We are trauma, gender, and culturally informed. This is something that we really wanted to focus on because we do have high risk, high need cases of mental health. We've had women who've come into the center, with trauma, with past trauma. So how can we make their stay as much comfortable as we can, and looking at, for example, because our center has double rooms, but probably looking at giving that person a single room if that person experienced abuse and things like that. So we really try to look at the trauma aspect and the cultural aspect, and in some pictures, which Gino is going to show, we do have a cultural room for Indigenous as well. And evaluating framework and fidelity scale. So like Bernie said, we wanted to really evaluate the service and see how effective, we did have these guidelines of, being flexible, having certain things. So having a fidelity scale keeps us on track of, this is a philosophy of our service. This is what we want to offer, and we're on the right track when it comes to that. So really getting into what our service is. So the service is really designed for individuals who are 19 and over who experience substance use and mental health issues, concurrent mental health issues. And it's a level of service that can't necessarily be provided in the community. So we're kind of like they say the last resorts. So they've tried other services, if it's outpatient services, mental health services, detoxes multiple times, then they would come to our center to have more of a structured program and kind of work on their issues with the psychologists and our clinical team. The concurrent and mental health addiction has a negative impact on their life and the social determinants of their life. We offer a bilingual service, so French and English. It can be challenging at times because we have to divide the groups when we do have more French people in, so it can be a little challenged, but we do offer bilingual services. The service is very goal oriented. Like I mentioned in the beginning, each individual has their own goal in treatment and treatment plan to address their concurrent needs. We provide a daily structure, which we find, and we hear that a lot in the last couple of years with the clients, is just having that structure of getting up and going to session and eating at a regular time and going to bed at a regular time as well, gives them that structure to kind of work on themselves as well. And it's really to increase and improve their quality of life. And one thing that I feel is very important in this program is the transition into community. So after 5 weeks, so they have to stay at the center for 5 weeks. After 5 weeks, that's when they can start doing their transition in the community. So basically they can decide to go home for a couple of days. They're still admitted with us, but go home for a couple of days and kind of test the waters, see how things go, come back to the center and really identify, what went well, what didn't go well, and what they need to work on. We found it very good for people to kind of transition them back into home and kind of preparing them for real life scenarios. With COVID, it was hard because we couldn't do that part. So we found it hard because it kind of went away from the philosophy of what this program is. But right now we were able to establish that again I would say in the last couple of months. And we've seen the difference in clients staying longer, feeling more confident in their program. And I mentioned that, we had and the clients are good to kind of say, maybe today I'm not gonna go home, or maybe this weekend I'm not gonna go home because things happen. So they're working on their skills as they're with us and realizing, okay, well, I'm in a high risk situation, I'm not gonna put myself there. So it gives them that opportunity to build their skills. And like we mentioned, we work to try to create a safe and collaborative environment for our clients. So we establish certain things there. So this is just a typical day at our program. So they're pretty busy during the day. So that's our schedule from Monday to Friday. So we do have, like I mentioned, we have an Indigenous room, a First Nations room. So we do smudging. It's optional for the clients at 8:30. So we have our occupational therapist does that with the client. They have a check-in in the morning. So our human service counselor does that with the client. So basically how they're doing today. And we have kind of a scale from 1 to 10. What is their scale today and what are their goals for the rest of the day to accomplish. Then at 10 and 1:15, we have our psychoeducational sessions. So there is more the clinicians, the social worker, and the occupational therapists that will provide these sessions for our clients. So there we had a French clients in our group at that time. So that's why the schedule is bilingual. And they have optional, like there's optional exercises. So they do like 10 to 15 minutes exercise. So that's optional if the clients want to do it. And at 3 o'clock, again, meditation is optional for the clients, but they tend to like the meditation. So they tend to all go. And at 3:30, that's the wrap up. So they wrap up their day. And that's when they go again with the scale and how they're feeling at the end of the day, and if they accomplish their goals. So pretty much in the evening, they have free time. And now that they can have passes, their curfew is 9 o'clock, 9:30. So working from a gender-informed approach, the way we function, and we've evolved because we've been open for a couple of years now, so we evolve our practice. But having weekly multidisciplinary meeting and treatment planning for our clients and our female clients as well, having a collaborative approach with our team members. And when we talk about our team members, not only our clinical team, which includes our doctors, our social workers, psychologists, our occupational therapists and psychiatrists, but the nursing team as well. So they're part of the care of our client, and having that collaborative approach for us really helps with the stay of the client. And every decision that is made is a team decision. It doesn't fall to one person. So, we have a team discussion about certain situations, and a decision made with the team. Is not me as a coordinator, or it's really the team that will decide what's happening. Daily safety huddle. So we do meet daily just for like maybe 15 minutes just to check in on how the clients are doing, if there's any concerns of that day, medication change and things like that. Individualized safety plans. So if we have, for example, maybe a problematic behavior or a situation that can put other clients at risk, we'll do individualized safety plan with the clients. And in those safety plans, we'll establish with the client strategies to help if it's, for example, the client is triggered easily and their emotions are very reactive and intense. Well, we'll write down in that safety plan action that they can choose and they identify with us. I'm going to use the sensory room. I'm going to go talk to staff. So that helps, with the communication as well. But like I mentioned, First Nation cultural family room, a trauma, gender, culturally informed care. We use a harm reduction approach as well. And I think that for us is a game changer. We've been using that language a lot more in our sessions with individual sessions with the clients and group sessions with the client to have that kind of harm reduction approach and for them to understand what it is, and for our team also to understand the harm reduction approach. For example, if a client is out on pass and uses while on pass, it's not an automatic discharge. We'll readmit them. And we'll continue working with them while they're in the program. Because, you know, we all know recovery is not easy. There's bumps in the road, and it's just for us to kind of pick up and look at how we can help that person. We also use specific trauma-specific treatments. So emotion regulation, DBT, we do use some tools there to help with emotion regulation. We do have our psychologist who is trained in EMDR. So she will, if we have in a team meeting, evaluate that the client would benefit from that type of treatment, she will evaluate and from there determine if the client is a good candidate or offer other recommendation to help with the traumas as well. We do a lot of mindfulness exercises, which that falls under our OT, which she does a lot with the clients. And then I'll pass the ball to Gina.
Thank you, Marie-France. Well, I'll take just the privilege of having the microphone, just maybe a little note here to thank Portage for putting this symposium together. And also on a personal note, I have a family member, a young man who actually benefited from Portage services in the past year. And it's probably the first time he has a smile on his pictures. So I gave back life to this young man. So thank you very much for all the hard work you do, very appreciated. So back to the transformation of our services. So first thing I would say, any services out there that are on the journey of transforming any services, there's two important things to remember. One, obviously, as the service providers, we always have to keep an open mind to new practices or new research coming out. So we always have to improve how we do business. We just can't stay static and do the things for over and over. Research does discover new things. And the second thing, however, is that we can't throw everything we know and all the experience we've gathered out through the years. So we do have knowledge when we move forward. And the reason why I mentioned this is that when early on our team, when we announced that we were transforming our program, there was a level of anxiety within our team, and it's as if that everything we thought or everything we knew over the year was just gone. So there was the high anxiety. So my suggestion is, all the hard work, everything you don't throw it away. You just build on what you have. So anybody out there, this is a little token of suggestion. So we opened in September 24th, 2018. We started slowly, a couple of clients just to test the waters because it was a significant change for us, not just in terms of length, but the whole delivery service, how we were doing business. We work on a first come first serve in terms of referrals. However, we've kind of modified a little bit throughout the years on that note. Because sometimes people, we try to get a hold of people and they're not available. So we just go down the list quickly. And if sometimes we will take somebody who is just recently called, if we can't get a hold of nobody to come to the treatment. So we're trying to be a little bit more flexible on that note. We do have referrals from all over the province. 60% are male, 40% are female. Now on that note, I don't think there's less female that have substance use issues. It's probably maybe they have a lot more barriers in terms of accessing our services. So that's something we can talk about a little later in my slides. Our women tend to be younger, average 40 for male and 37 for female, and our length of stay or average length of stay is 45 days. Quick I'm sorry for that. Some quick stats here. So when we do ask our participants or our clients, what their consumption of choice are or what they consume, and as you can see, alcohol is still number one of our clients. We sadly hear a lot about, other substances that have a harmful impact, methamphetamines and opioids, which are also on the board, but never forget that alcohol is still a major player in substance use issues for men and women. Most of our clients, or many of our clients, are polysubstance users, which is very common also. In terms of, because we are concurrent disorder, so we obviously have a high interest to understand what, their mental health issues are. So some of the stats here you see in front of you, which would not be a surprise. Anxiety, 79% of our people, referred, acknowledge having anxiety issues, and depression, 63%. And then you have others like trauma, 34%, which is probably underreported. Probably people don't say that they have trauma, but actually have it. So that we have to be careful for that one, because most people probably have, especially our program, have trauma. And severe mental illness, for example, schizophrenia, 20%, and other mental health issues, 19%. So in terms of experience, so we do gather some information on how people experience their stay with us. So here are a couple of stats. Generally speaking, 98% report having excellent experience during their stay, and 95% feel safe on the unit. So specifically on that one, a very high interest in terms of service delivery. Very important that clients feel safe while coming to treatment. If there's one area you want them to feel safe is in treatment. If you don't feel safe, as you know how you can open up and start your journey to recovery. So feeling safe is very important to us. 70% report improvement in problematic symptoms. 81% report being better prepared to deal with daily problems. And we measured also pre-change, which post-change of our transformation. And pre-change, we had 67% of people completing the program, which was the old program. And in the new version now, we have 80% of people completing the program. And we dare to believe that, because it's so highly individualized to everybody's own needs, that, more people are finishing their treatment. The other thing I would know before going to the other slide is that, which is very important to us, is a reputation. It's hard to measure that, but the reputation of all centers, of all treatment services, is highly important. It is for us anyway. When we do sessions with clients, and when they leave our treatment center, how they would talk about our center is very important. Would they say, well, when you go to Hamilton, it's don't go there, it's a bad place. Or on the contrary, say, you know what, I found hope, I found my life again. And those people will go back in their communities and talk about the center, and other people maybe would want to come to Hamilton. So we really cherish that, the reputation of our center, and what clients think about us is very important. The other thing is also important is that the indicators among staff, what we often ask is about how do we measure success? And so there's so many things out in the literature how you measure success, but one of the most important indicator, which came one from our colleagues, and I think this is one question we ask ourselves: if you're working in any facility, any services, would you refer your own children, your sister, your brother, or your spouse, if they had a substance use issues, to that service? So when it comes right to the heart, and if you say, you know what, I think I would refer to this service, this is a great service. If you refer a family member, you're probably doing pretty good as a job. If not, maybe there's some work to be done. A couple of things that their feedback of clients have said, which is very, keep me organized here. So these are the words of women that pass through our services, and I think it's important to read a couple of them. Actually, I'm going to read them all. First one, she says, the individualized treatment plan, the staff, daily access to social workers, goal setting each week, encouragement to pursue fun, healthy activities, how staff modify sessions and the energy in the group, EFT tapping and trauma sessions. The other one said, I'm recommending this program to all my closest girls who are lost down the same road I was. It's you guys who brought to me out of my shell and helped me guide on the right path. I couldn't have done it without everyone here. The other one said, the sessions with the psychologists and psychiatrists changes in my medication, and meetings with social worker. We go on with this other comment. Each person had their own program and the outside resources were very beneficial. Example, EMDR and sleep clinic. And the last comment, which is important to know, is the entire staff work as a team, each having their individual strengths. So challenges for a woman that we've noticed, and I'm not going to go through all of that list, but there's a couple here I would like to mention. And we've mentioned a while ago, you know, Dr. Poole had mentioned some of this here, and we've mentioned the presenters. Post-treatment housing and post-treatment, I mean, a major issue. Although our clinician and our team work a lot on treatment and counseling, we have a lot of time invested in case management and helping our clients find, you know, some resources, you know, that they feel safe going back to. And a lot of the times that's not the case. So that is a big struggle for our women. Access to childcare. It's not rare for Marie-France, when Marie-France calls clients or female clients to come into the program, their first question is, well, who's going to keep my children? So I'll get back to you. I'm going to have to find someone to keep my children. So that's a major barrier that our women have in front of them. The other one is stigma. You know, we hear a lot about stigma. This one here is very particular. What I would mention, which I was kind of a little tidbit of information that CCSA had come out in their campaign of, you know, stigma stops with me. They had mentioned one of their documents that the World Health Organization has stipulated that people with substance use disorders are probably the population the most stigmatized in the world. So imagine being a woman with substance use issues and being Indigenous on top of that. So you're talking about major stigma of our people coming to our doors. And the way we deal with that with women, we always ask them, we have a lot of things to do on the outside with our partners and society, but how you talk about your own inner voice, how you talk about yourself, for example, when you relapse. So we ask people, start, you know, the stigma and start with, you know, how your inner voice talk to yourself. Instead of saying, you know, good, you're an addict, you know, you're somebody with a substance use issue and you're a good person, you just have relapse and you have a health condition like any other person. So that's very important for women to understand that. Less women are referred than men, mentioned that a while ago, 38% of women and 60% are men. Then again, it's not because there's less women, probably more barriers. So our successes, again, I will not go through the whole list, but a couple to mention. Increased teamwork, very essential, how the team works together. There's days our services was us and them, different professions were competing against each other, was nurses against social workers and vice versa. This is not my job, this is your job. You know, I dare to believe that we've gone a long ways from that, and now we have a tight-knit, respectful team that everybody has a say. Even have a peer support worker sometimes around the table, or people live experience, and everybody has an equal input into the team, and obviously the client also. Our First Nation Indigenous involvement has been key for us. I'll show you some pictures after. This was not only a nice add-on, was a necessity, as we can see now, and how it's used and how it's integrated into our services. And the last thing I would mention is also the case-by-case individualized approach has been key for us also, versus, you know, everybody fitting in the same, you know, cookie cutter program. So key factors to consider, a couple here I would mention. Change management. I mentioned that earlier when I started speaking about the necessity of, you know, going as a team, but also not forgetting what we've learned. The individualized approach, which I just mentioned, very flexible, which is also a key factor to consider for anybody going on this journey. The other one, which we cannot miss, is the client feedback. I'm always surprised how important it is to involve people with lived experience, family members and clients into the quality improvement of our program. Get them involved, ask them what they think. One little example here is that for some of you may know that we're having a new facility in year 2023, and one of the questions we ask our clients is, you know, did you want TVs in your room? So we had, you know, some money for that. And one of the clients says, you know, no, we don't want TVs in our room. We don't want to be isolated. So very important to, when you do changes in your system, to involve clients in all aspect of delivery. And Marie-France touched on this about the trauma-informed care, which is very important into our services. So finish off before what we need to improve services, a couple of pictures. So here, the first picture, quickly, you have, maybe just show the door again. I'll just mention this. Horizon Health and Vitality were in collaboration with all First Nations communities around the province. And as you see on the door, it is kind of a sign of reconciliation. If every community had their own artist design of kind of a wheel with both health networks, so that we are united into the First Nation in reconciliation. So the next picture, we have our First Nation room. Obviously, it's a nice picture, but it doesn't do justice as when you really physically walk in there. So this is First Nation. We do our sessions in there, you know, smudging and do a kind of ceremonies. And this room here was done with elders and First Nation communities. Nice, beautiful painting on the wall, as you can see. A very highly utilized room in our center, very inclusive. Before we go to the next picture, what I would mention for First Nations and Indigenous is that, you know, obviously, if you are Indigenous or First Nation and you come into it, you feel included, you feel that, you know, you're back to your roots, but also all cultures benefit from this. And we benefit from, you know, all the learnings and the teachings of First Nations, and such a sign of a reconciliation, and so much now that we need this in our journey. And this is our sensory room with our occupational therapist kind of leaded this room here, all about the emotion regulation, but a nice, the importance of, you know, dealing with trauma, but in terms of relaxation techniques. Also, you have the waterfall, the sensory, and then the next picture, you have also the gadgets that you have to, you know, the fidget toys where people need to have the regulation when they're dealing with emotions. This room is particularly interesting for nursing staff. Nursing staff, a lot of times when clients will go to them and say, you know, they want a PRN or they want some medication, a lot of the nursing staff will say, well, why don't you go try your plan into the sensory room? And often than not, they'll be able to regulate their emotions within this room versus, you know, taking medication. So that's a nice add-on for our service. Move on here, our wall of hope, you know, message of hope. So clients are voluntarily asked to write some messages for other clients when they come in. So a beautiful wall. This here is a part of Safe Word model. For the ones who don't know, Safe Word model is an international model, and if I'm not mistaken, has started in Australia. So there's 10 interventions for Safe Word models for psychiatry and substance use units. And this, what you see here is pictures of staff that we hang into the corridor, which basically says, you know, we know each other. We get to know you. You should get to know us. So you have pictures of staff and what are their own interests, what are their hobbies, who are they? So it's a nice starter conversation when clients come in the first time and they see that. And if you see somebody say, holy geez, you like the Montreal Canadiens, you know, so they start a conversation with that, or you like knitting, you like pottery. So that's a very nice add-on for our service. Therapy rooms. Then you got the lounge. Nice gym, pool table, and very important also for recovery. Why stop using if you don't have a healthy lifestyle or something to, you know, to wake up to? Some of the outside of our building, which clients will work in the gardens. You probably see on the building on the right, you have a garden there. It's probably early in the spring or early summer because you can't see it growing, but there's some gardens there, so clients work into. So on the last thing, a couple of things, how we need to improve as a service, always room for improvement, even though we're pretty proud of what we've created. Never forget, never put your head down and think that you got it made. There's always room for getting better what we do. Now for specifically for women, obviously there's a couple of things I'd like to mention. Number one, reducing stigma. We've mentioned this throughout even this morning, we talked about that. The housing piece, very, very important, how we collaborate with our partners, and we want to, you know, a lot of women and clients, they do a lot of good work, but if we return them to situation or high risk environments and places where they started off, they're not comfortable, it beats the purpose. So we need a lot of work around that. Other things, we're having a new building, and anybody who is in construction business or they want to look at having new centers. I think one of the things that I believe and our team believes is single rooms. If there's any part of healthcare that you have single rooms, it should be people with substance use issues. We have double rooms right now, and it's not just a logistic issue, it is also in my mind not trauma informed. So single room is very, very important. The other thing I would mention is we're continuing developing guidelines or adopting principles that are trauma informed and gender specific. And one of the things, for example, we need to continue at this. We need to get rid of rules. A couple of pages of rules to more of a code of living, which we've transformed, and not exploiting people with substance use issues by treating them differently than we would do in the other healthcare setting. So that's very important. And lastly, well, thank you very much for participating, and specifically the team that we up home that helped us out to transform this program from people with lived experience, family members, all their clinicians and the medical team, the central office with Bernie and upper management and all the team that's worked hard for helping us this year. So thank you very much.
Is it on? It's on. Okay, so we do have about 20 minutes before we wrap up this, which is great for the Q&A, because what I've been learning about the Q&A is that the questions are there and people want to ask very thoughtful questions, and they're looking forward to your very thoughtful answers. So Tammy will be sharing some questions we have received already from the Q&A. So once those are answered, I'll turn my attention to the people here in person if you have any questions. Tammy?
So this writer actually has a couple of questions. Firstly, she's asking, are there safe injection sites offered in this province? And her second half of that question is she's wondering about, do you have, or do any, of your inpatient treatment facilities accept clients on methadone or Suboxone? Suboxone.
I'll start by answering the first one. We just have our first safe consumption site in Moncton that started within the last year. I'm not sure of the exact date. That is delivered by a group called Ensemble, and they do fabulous work. And there's plans to expand that service to other areas as well. Maybe perhaps the bigger centers such as St. John and Fredericton in the future. But right now we do have one Ensemble, and there's also a harm reduction clinic in St. John. I don't know all the details. I think it's called Riverstone, and they do amazing work there as well. I'm not sure if they have a safe injection site, but they do offer a very comprehensive harm reduction approach. And in terms of the other question is if clients are admitted with Suboxone and methadone, my answer is yes.
Yes,
Yeah.
yes, we do accept clients who are on methadone or Suboxone.
Thank you.
J'inviterai s'il y a des questions de la salle. Any questions from people in the room? Yep, we've got Dave coming up.
Hello there. I have a couple of questions. First of all, I want to congratulate the three of you and your teams for the work that you're doing. I guess my first question really, maybe it's tough for bureaucrats to answer this. I don't know. But it sounds to me like the number of beds that are available are woefully inadequate. And if we're talking about even this symposium is about women, and I'm just wondering, what kind of waiting list is there for women to access the program? That's my first question. Do you have any idea?
Do you want us to answer them as we move forward?
Maybe I'll ask 2 or 3 questions and then you can. The second question I have has to do with what does it cost per person per day to receive the treatment? I know it's Portage Atlantic, it's information we have to provide to the government funders, and I'm wondering what your costs are compared to ours. And the third question I have is, do you have any experience yet with what the success rate is 12 months after the people have left the program? Because that's, again, a question we get asked all the time, is how successful were you? Not the day you left the program, but 6 months later, 12 months later, are you still sober? What percentage of the people are off are still successful? And those are my questions.
Okay, maybe I'll start off and
You wanna
feel
start
free to
off?
jump
Okay,
in. Yeah.
yeah.
So in terms of the number of treatment beds, yeah, I think we do need more treatment beds for concurrent disorder or substance use treatment as well. We've had some preliminary research partnerships done with a model called needs-based planning. And I don't have the specific numbers, but it does suggest that we need significantly more beds in New Brunswick based on the needs of the population in terms of what we would know. So that's one of the reasons why we're increasing the beds in Campbellton once the new building is complete, and hoping to add some beds in Ridgewood as well. That probably still won't be enough, but it's a start. It's a starting point. So we do recognize the need for more beds. And the second part of that question was?
Our services are covered through Medicare. So as long as the individuals has a valid Medicare number, they can come in.
Yeah, okay, so you're talking in terms of like the government cost for that bed? Per bed, yeah. I don't have the number off the top of my head, but I can definitely get back to you with such a number, yeah. And the other questions were?
Yeah, in parts of the the outcomes, probably 12 months later. So I guess but we didn't put it in our slide, but maybe that's one thing we need to probably get better at, is measuring a year later how people are doing. But we do measure, during and late after the program in terms of the mental health issues or substance. But we don't have any data in terms of at that point.
And I think Gino mentioned also during his participation is success can be measured in different ways, right? It's not just about if a person is absent or not. It's about their quality of life. Do they feel better? Do they feel more connected? Have they reestablished relationships? Maybe they're working now. So some of those things are really longitudinal in nature and difficult to measure. But we do know that within the program, we look at some assessments before, during, and after, and clients do seem to get better in terms of being able to better manage their symptoms post-treatment afterwards. And we do know that it's a very high satisfaction rate. But I think in terms of longitudinal studies, that's definitely an area that we need to do better in terms of researching and measuring outcomes as well. So it's not just about keeping beds occupied and how many people we put through. Is our people actually getting better? Good questions. Thank you.
Dr. Poole, you have a question or comment?
Congratulations. I mean, that is so good, what you've been able to do. And that idea of, treatment not happening in a magical 21 days is just fundamental to the whole thing. And I'm really glad you raised that. I'm kind of interested, just given what you said about who your clients are and et cetera, and what substances they're using and all that jazz. About what you think you might need as you develop more gender-specific programs that are around depression and anxiety and benzodiazepines for women, or is that around trauma and violence connections? Is that around healthy relationships with children, physical health issues? I mean, you can imagine I know a whole long list of things that might be relevant, and I'm just wondering what you're hearing from the women, or whether you've done that yet of specifically thinking about what those gender-specific program development pieces will be.
Yeah. So again, I think that, well, great question. And I think we need to, when I mentioned a while ago, quality improvement, how do we always improve what we do in the voice of women? So we constantly, and actually when we were asked to participate in this, this symposium, we asked ourselves the question, how do we get better serving women? And so we got on the board of asking them, how do you feel about the service and all that? And it's kind of sometimes, other than the obvious ones, like, childcare and transportation and all that, it's hard to get really the opinion in terms of the women specifically. But we know, for example, that, violence or partner violence and stigma and all that, and we have to bring it out. And also there's a place for us to maybe have more specific women's sessions, not just co-ed everybody together, but to take them aside and have that, component for women alone, but also for men alone.
Yes.
Even though we are co-ed, there are some specifications, so we should certainly look into that. And in terms of substances use, we do know or are trying to explore, for example, amphetamine use. We had a couple of women say, well, we use amphetamine just to forget about, the prostitution and the violence and all that. And so we say, well, holy geez, we need to dig into that a little bit more as clinicians, as a team.
I have a question actually, or a comment. Just in reading the chat here, there were a couple of people actually that posed the same question about what is the cost to the province for providing the service? And I think that's a very good question. And as healthcare providers, we need to be responsible and spend and be fiscally responsible, I guess, right? And what we're doing and tailor programs to our clients. But I guess just on the flip side of that, I'm thinking, what is the cost to our society of not providing that service? Or what is the cost to our society of providing an underserviced service, or a service that isn't adequate or enough? And I guess I just look into my own role in my own job, is that we need to be able to answer about key indicators and what is success or what defines that. And so I'm sitting here listening to your comments, and I think in general, like, this is chronic disease, right? This is chronic disease management with a separate subspecialty entity to it, right? With all kinds of nuances and layers. And it's very difficult to think about or to define success on paper, I think, to stakeholders. And so that's a huge obstacle. But when you're looking at dealing with another subset of population as women and children, where do we go with that? And how do we show that need or talk about that need to government or to people that are offering funding and planning for these kinds of programs? And so I'm going to put you really on the hot spot here, but because I'm not an expert, but I really feel like you are. And I would like to ask you, what do you think needs to be considered when we're looking at what our reality is today in society? Where do we go from here? And I want to say again, I applaud you, on your program. I think it's amazing and it's a huge plus. But when we look around, it's not enough. And so where do we go to help it become more or to do better?
Yeah, I mean, those are the big questions, right? And I kind of just follow up with this morning's idea with the boat analogy. I think we are slowly turning the boat around. I think we're not just rearranging the deck chairs on the Titanic. I think we are heading in the right direction. And I think there's a lot of knowledge and expertise that we can use. And you see some of the synergy from this morning's discussion about having similar guiding principles and working together and reducing the silos and working collaboratively and having more wraparound service. I think those things are all kind of in place now. We're talking about developing a national dialogue and national treatment indicators for addictions and mental health services, so that we can start looking and counting in things the same way. in terms of, what's the wait time from assessment to treatment across Canada? How are we improving on those measures? How long do people wait from assessment to entering a live-in treatment service program? So we're starting to have those discussions and those dialogues and those plans in terms of those types of measures. I know I'm probably not answering your question, but if there's no easy answer to those types of things, and I think nationally, there's some really good discussions going on about having similar ideas, similar models, similar approaches, similar best practices, so that we can really start to work together and compare how we're doing, and always with the goal of doing better.
And in your statistics, it was very evident that women access the services less than their male counterparts. And as a woman and a mother, I am reaching here, but I feel like it would be, again, that shame, but also fear of maybe losing my children or being separated from them. And also, just the logistics of who's going to care for my child, like you brought that up. So how do we better that? So if you had services tailored to women and children, do you think that would improve the access, or that women would enroll for the program or seek help more often, more readily?
Yeah,
Well,
I suspect so.
Yeah, definitely. I think, Bernie talked about, the step care model. There's so many levels of care, but there's also so many gaps into the services now for women, that we need also a system. For us, we've lived during this transformation, so many working by silos and system barriers that, so imagine if you're a woman with substance use issues, they themselves often don't have a loud voice. So we have to be their voice. We have to we have to take a hard look on our own systems. And I think that that piece there for women in access and childcare, it has to be a multi-agency and government and communities to make sure that we bring that down, and we just don't, leave it unturned. But certainly some work to be done around that to access care, and childcare is one of them for women.
Thank you. And thank you for your important work.
Okay. Well, it has to be one short question because we're 4 minutes away from 1:30, and I know we have to get on the buses on time. So can we make it a quick question?
So we're from PCAP, so we work directly with women who have substance use disorder. And I think our biggest barrier is when we find that the women are ready for treatment, that we aren't able to get them into any facilities. So we know everywhere is waitlisted. We're just wondering basically how to refer, how long the waitlist might be, and also what the center is called, so that if we were looking to make a referral, how we could do that. And if you service just the region of Campbellton or kind of all of New Brunswick, or so those are just our questions.
So we do, because we only have one service in well, two now with St. John. So I was pretty happy when St. John transformed, because it puts, we only have two services in the province. So we do have a long wait list. And like Bernie mentioned, we do only have, well, we have 10 beds now due to COVID. So the access is not there. So we do have a long wait list. Our program is called the Living Concurrent Disorder Treatment Service. If you want, I can connect with you afterwards, and I can send you like the referral forms, all the information, if ever you want to refer one of your women to our program.
Okay. Thank you.
And it is provincial in nature.
Yeah.
Okay. Merci beaucoup à nos panélistes. Thank you for the excellent showcase. On a great, I love it when New Brunswick, like I'm very pro New Brunswick, like I love New Brunswick, and I love it when we have a great success story and something to show off to our partners from other provinces. Alors, bon, il est 13h30, it's 1:30. Just a little bit before 1:30, so les autobus nous attendent juste à l'extérieur. You'll see the buses. So the buses will be leaving at 1:45, 13h45. The travel time is approximately 1 hour to Cassidy Lake. So yeah, hop on the bus, enjoy your visit. For those of you participating virtually, we will see you tomorrow morning, but if you are interested in learning about Cassidy Lake, there is a link on the website for Cassidy Lake. So yeah, and we will see you back here at 6:15, 18h15.
Baby, zet je magie op mij. Ze wilt een champagne shower nu ze ziet dat ik draai. Moet mezelf inhouden als ik zie hoe je wine. Kan niet van die police houden die we zien in de wijk. Hey, Habibi, je moet werken voor me. Ga naar beneden, je bent lenig, schat je brein het voor me. Terug naar boven, mijn money geeft je grote ogen. Ik weet je money, 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 laat je overlopen.
Je doet het voor de money en de likes. Zat vroeger achterop bij elke brommer in de wijk. Ik gooi alles op mijn moeder, daarom valt ze niet met mij. Maar ik kom van beneden, meisje onder het tapijt. Dus spreek me niet aan, want dat is zonde van je tijd. Ik geef geen rondjes in de club, ik geef rondjes in de wijk. Ik heb de touwtjes hier in handen, daarom word ik niet genaaid. Zie me gassen met een lach, maar geen ballonnetjes voor mij.
En hoe je doet, en hoe je kijkt, en hoe je moved. Niet van mij, baby, kom op. Zet je magie op mij. Zet je magie op mij. En hoe je doet, en hoe je kijkt, is hoe je moved. Niet van mij, baby, kom op. Zet je magie